She's excused.
Michael DeToy. Monica Erickson. Troy Johnson. Patrick Henning for Fiona Ma. Lisa Middleton. Kevin Pauke. Ramona Rocava. Yvonne Walker. Melissa Ouellette. Dr. Gail Willis.
She's here. She'll be here. All right, with that, good morning, everyone. Welcome to day 2 of our board administration and executive team offsite meeting. Like yesterday, today's meeting is being streamed online for anyone who'd like to tune in. We're joined in the room today by stakeholders and members of the public who have traveled and made time to be here to learn alongside the board. Thank you all for being here in person and online. We value your participation and engagement. So after each presentation, there will be public comment period for anyone who wants to share their thoughts. And for those participating online, the call number is 1-800-259-4105. Again, that's 1-800-259-4105. Our stakeholder relations team will be standing by to assist. So I'm going to go over and give you guys a bit of a preview. Today's focus is leading up to the lunchtime will be healthcare, starting with action items on health maintenance organization contract with Sutter Health Plan. It will replace our United Healthcare plans, which the board voted to discontinue last month based on proposed premium increases our staff concluded were excessive and unsupported by market or member data. Robert Jarzombek will lead us through Robert J. will lead us through the details of the contract for approval and then move on to our second action items of the morning, finalizing the health premiums for all our 2027 plans. And then we'll look at the proposed employer contribution formulas for state annuitants, followed by premiums for our association plans, including the California Association of Highway Patrol, California Correctional Peace Officers Association, the Peace Officers Research Association of California. And then next we'll hear from Dr. Logan and Dr. Elizabeth Albers from our Clinic Policy Programs team. They'll be walking us through some updates on how we are working to improve members' health outcomes, along with efforts to enhance the behavioral health services we offer. And then we're going to have a break. And after the break, we'll hear from Dr. Don Moulds, our Chief Health Director, and his team about the methods we can use to enhance our regional health coverage throughout California. They've had some wonderful success in this last year to expand coverage in far northern California and northwestern Nevada, and I look forward to learning about how the work will continue. And I always want to congratulate Don. He's always looking for more ways to get more service to our members and to make sure that it's accessible and affordable. So I always want to tell you how much we appreciate that. That will be followed by a presentation about the application of artificial intelligence in primary care. After lunch, we'll come back for fiduciary training and a closed session about our fraud security roadmap, which we'll report out before we adjourn. And with that, I will turn that over to Rob. I am not saying your last name until you tell me how it's correctly pronounced.
That's all right. Good morning, Madam President and members of the board. Rob Jarzombek, CalPERS team member. This is an action item requesting your approval to enter a new contract with Sutter Health Plan. Sutter Health Plan is a fully integrated health plan that started in 2014. It operates in a coordinated way across its clinicians and hospitals, similar to other integrated plans in our program, such as Kaiser and Sharp. Plans with this kind of integrated structure often achieve stronger clinical outcomes because care is better coordinated. In addition, it receives high ratings on quality and service through NCQA, which is the National Committee for Quality Assurance. Sutter Health Plan serves about 115,000 basic members across 16 counties and has a network of 8,000 clinicians and 33 hospitals. For CalPERS, we are recommending a 6-county service area, as this largely matches the service area that UHC Alliance has with the Sutter Health System. These counties are Placer, Sacramento, San Joaquin, Stanislaus, Solano, and Yolo. We recommend entering a 2-year contract with Sutter Health Plan, as this will align with the end dates of all of our other HMO contracts. The contract with Sutter Health Plan will contain the same strong terms and conditions that we have in every. Also, for this arrangement, members will continue to have their outpatient pharmacy benefits provided by CVS through CalPERS contract, which is how this is set up today for UHC Alliance and Harmony members. While we see a lot of positives about contracting with Sutter Health Plan, we want to acknowledge that there is no exact replacement that fully replicates the experience that UHC Alliance members in particular have today. There are a couple of considerations to mention. The first will affect members in combination plans. A combination plan is where one member of the family is in a basic plan and another member is in a Medicare plan. This creates a challenge for the approximately 800 families or 1,800 members who are in UHC combination plans and receive services through Sutter Health System. Through conversations with Sutter Health Plan, creating a Sutter-based Medicare Advantage plan for January 1st, 2027 was not feasible given the short time frame, and having one in place for a 2028 start or beyond is much more realistic. Without a Sutter-based Medicare plan, current UHC combo members will have to find a new plan with both a basic and Medicare product. It's important to note that this is not a unique challenge. Neither HealthNet Saluti Mas or Western Health Advantage basic plans have a corresponding Medicare plan. And for years, the same was true for Blue Shield, Anthem, and Sharp. Another area of potential member disruption is behavioral health. Currently, UHC Alliance members use the Optum Behavioral Health Network. However, Sutter Health Plan contracts exclusively with Carlin for behavioral health services. We are working closely with Sutter Health Plan to determine the current provider overlap, which Sutter estimates at about 80%. Specifically, we are working with Sutter to identify high-impact providers in clinical areas so they can potentially add them to the network to achieve the most continuity as possible and better access for members. We raise these as we want to be transparent about the areas that could cause member disruption. We strive to make transitions like this as seamless as possible, but that will not be the case for some members. Let's review UHC's 2 basic plans that we recommend exit the program to better understand the service areas and access the Sutter Health Plan can fill, and how we will accommodate members outside of those areas. UHC Alliance is in 26 counties throughout California. It is the only mid-price plan that provides members access to the Sutter health system in the greater Sacramento area. With the exception of Sutter, other HMO plans, such as Anthem Traditional, Anthem Select, and Blue Shield Access Plus, provide access to the same providers in the Alliance network. There are just over 80,000 members in this plan. Harmony is a narrow network plan in 10 counties. All of the providers in the Harmony network are also available through other HMO plans. There are about 13,500 members in this plan. Now let's talk about how we're going to support our members through this transition. Starting this month, we will begin our communication campaign to both members and employers, informing them of the upcoming exit of UHC Alliance and UHC Harmony. We will encourage members to compare and select the best plan for themselves and their families during open enrollment. While we will do our best to map the most appropriate plan for members as part of CalPERS' administrative transfer process after open enrollment, there may be specific clinician or facility preferences that we can't predict or know. Therefore, we strongly recommend that members use our online tools to help ensure they will be in the right plan come next year. Let's talk more about the criteria we use when setting up the administrative transfer process. When there is a plan termination or exit from any service area, we need to determine the plan for members to be transferred into should they not make an active choice during open enrollment. For the UHC Basic Plans exit, we're looking at this from two key angles to ensure we transfer members to the plan that makes the most sense. The key criteria are primary care provider continuity and premium impact. We look at primary care provider continuity to ensure the member and their family can continue with the same provider relationship they have today where possible. For this, we strive for a match with the medical group associated with the matched primary care physician. Just to underscore, there may be other care providers, such as specialists or behavioral health clinicians, that are just as important to the member. But for the admin transfer plan, our match is with the medical group of the primary care provider. We also look at the premium impact to members. We want to transfer members to the lowest price plan that allows access to their provider's medical group. These are the specific plans that UHC Alliance members will be transferred into by county. These plans are Anthem Select, Blue Shield Access Plus, and Sutter Health Plan. This slide outlines what UHC Alliance members can expect. For those in the greater Sacramento area, they will be administratively transferred to Sutter Health Plan so members can continue access to the providers and care teams they are seeing today. These members will also continue to receive their outpatient pharmacy benefits through CVS. For Alliance members outside of the greater Sacramento area, depending on their county, they will be transferred into either Anthem Select or Blue Shield Access Plus. Members who will join Anthem Select will continue to receive their outpatient pharmacy benefits through CVS. For those moving to Blue Shield Access Plus, they will have outpatient pharmacy benefits through Blue Shield, as they provide these benefits themselves and not through CalPERS' contract with CVS. And finally, while our goal with the admin transfer plans is a match with the medical group of the primary care provider, this is a large-scale effort. So we encourage members to use our online tools to confirm provider availability. If they are satisfied with the plan they'll be transferred into, no action is needed. But as always, we will encourage members to compare their options and make the best choice for themselves during open enrollment. Now let's look at the admin transfer plans for Harmony. Given Harmony's unique service area, there are 4 different admin transfer plans, which again vary by county and are shown here. These plans are Blue Shield Access Plus, Blue Shield Trio, Sharp, and Western Health Advantage. Here's what UHC Harmony members can expect. For those members moving to a Blue Shield plan of Access Plus or Trio, they will have outpatient pharmacy benefits through Blue Shield, as they provide these benefits themselves and not through CalPERS' contract with CVS, as I mentioned earlier. For members moving to any other admin transfer plan, which are Sharp and Western Health Advantage, they will continue to receive their outpatient pharmacy benefits through CVS as they do today. Again, because the admin transfer plan prioritizes provider continuity over cost, there may be instances where a lower cost plan is available to the member, particularly if their primary care provider isn't their highest priority. Member support during open enrollment is always important, and with the exit of UHC's basic plans, it's even more critical this year. Therefore, we will use our tailored member letters as a way to explain the situation, provide information and resources, and help members make an informed decision. Members will also receive an email and a custom message on their health plan statement. In addition to the tailored member letters, we communicate through a variety of channels between July and October. And in September, we'll host our annual member webinar where we'll explain all of the health plan changes in detail and where members can submit their questions to us for live answers. Also in September, the Sutter Health Plan Call Center will be ready to take calls from CalPERS members to answer their questions during open enrollment and beyond. For our employers, we extensively communicate health plan changes to ensure they have what they need to assist their employees with any questions or concerns. We sent a circular letter out last month that provides an overview of open enrollment resources and this month they have an opportunity to request an open enrollment health fair with our health plans. And just as we do for members, we hold an annual webinar for employers in September where we provide details on upcoming plan changes and where they also have the opportunity to submit their questions. For next steps, once the board takes action, we will continue preparations for the implementation of Sutter Health Plan. Additionally, we'll begin our communication activities to members and employers in advance of and throughout open enrollment. This concludes my presentation, and we're happy to answer any questions.
Rob, thank you very much. That was a really good presentation, very thorough. Are the board members able to use any of these tools so that we can talk? Because we're already getting, member inquiries.
Yes, so part of our communication plan is to create information for you all to use. We're actually updating our website today or tomorrow, this week, I should say, with all of this information where everyone can see it themselves, members and employers as well as the board. We're also preparing newsletters for any of our stakeholder groups or employer groups who might want to help get that message out. So there'll be a variety of communication tools for everyone's use, including the board.
Okay, perfect. And then you said in August you guys would support health fairs to go out and talk about this.
Yes, and so through our annual open enrollment process, this is where employers have the opportunity to host a health fair or an open enrollment fair. And so this is where they can request that online through our tool, and then the health plans will, based on their availability, go out and participate in those health fairs, whether it's in person or virtually or a combination.
Okay, thank you, because I'm going to probably tell my folks that they can do that.
Yes.
With that, I have Yvonne Walker. I don't know who was first.
Troy.
And Troy was first? Go ahead.
Thank you. Through the mapping that has been done, do we know how many members are a percentage of our members that are able to keep their primary care provider, thus ensuring that continuity of care?
Yeah, so it's a very high number. So we matched it with, in the 6 counties in Northern California for Sutter Health Plan, we believe it's close to 100% match because those members are currently going to the Sutter Health system for their care. In the other counties, we did this extensive exercise to determine the most appropriate medical group. So we're matching it to the medical group of the primary care provider. It's 100% in the majority of counties, since I think the lowest county was in like the low 90s of overlap, and so it's a very high number of overlap with the with the medical groups. For facilities, it's even higher. It's nearly 100% everywhere.
Great.
And so this is what we were able to do to ensure there's continuity there. There is a lot of overlap amongst our plans.
That's great. Thank you.
Sure.
Ms. Walker?
Hey, Rob. Outstanding presentation. Love it. So I think you should start these because it comes up for me all the time going to retiree meetings that this is for
Yep.
active. We should just neon light that all
keep
the
saying
time.
that.
Right.
Okay, so this is for the basic UHC Alliance and UHC Harmony plans. This does not impact UHC's Medicare Advantage plan.
Right.
UHC's Medicare Advantage plan will still be part of our portfolio in 2027.
Everything we put out, we should,
Yep.
that should be like the banner headline.
Yes.
And then, go into everything else because, it creates anxiety. And then another idea while you were talking that I had, and I think your communication plan is great, but is there a way to do like a letter with the Sutter folks so that when people go see their primary care doctor can say, oh yeah, by the way, you're gonna be switching over here directly, blah, blah, just a regular,
So
that would be kind of another layer of,
that is part of our letter,
Oh, is it?
our
Oh,
tailored
cool.
letter process. So
see, we
with
think alike.
We do think alike. With the exit of any plan, that member is going to get that letter, and so those UHC Alliance members in the 6-county area are going to get that letter that says you will be enrolled into Sutter Health Plan. And then we're also working very closely with Sutter Health Plan and UHC to continue the same PCP assignment where possible, so the member doesn't have to go through that hurdle of getting back to the one that they had previously.
I was thinking more in terms of as they go in to see their PCP. Their PCP says, oh yeah, by the way, did you know, blah, 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 and you're gonna come here, and I'm gonna make sure I keep you, or something like that, kind of thing.
Yeah, I'll just add one. It's a terrific idea. Two, one of the nice things about this arrangement is that Sutter Health Plan and Sutter Health System are very closely related, and so the possibility of having that kind of more direct communication with the providers that work in the Sutter Health System is real. So we've been talking through the opportunities like that. That's a great additional one. So if it hasn't occurred to somebody, we will make sure it occurs to somebody. But we're very excited about this arrangement for that kind of reason, among other things.
Right.
Kevin Palkey, go ahead.
No, I just want to thank you for the work that you've done on this. I know it's always tough for our members to go through change, especially when it comes to their medical benefits. So to see that you've put in the effort to get as close as apple to apples as possible, I truly appreciate it. So thank you.
Thank you.
Oh. And if there's no other comments, I'd like to make a motion to approve the new health plan contract with Sutter Health Plan starting January 1st, 2027 to December 31st, 2028.
Thank you. Do we have a second? Seconded
I'll be
by,
happy to second the motion.
all right.
Madam President.
Motion made by Mr. Palkey, seconded by Mr. Rubalcaba. Do we need a hand vote, or do we? Okay, so all those in favor say aye. Aye. All those opposed? And any abstentions? All right, motion carries unanimously. Thank you very much. Huh? Nope, I don't have public comment, right? No public comment? Okay. All right, so thank you, Rob. Great presentation.
Thank you.
I think you answered all our questions. And then, so that means we're gonna move on to our next action item, approval of the 2027 Health Maintenance Organization and Preferred Provider Organization Plan premiums. And that again is Rob Jarzombek. I
Very
got it.
good, yes. All right. Thank you, President Taylor. Good morning again, everyone. This is another action item to approve the 2027 HMO and PPO plan premiums.
That's time.
So here's our agenda for this morning. We'll begin with a summary of the recommendations, which we've been discussing in the recent months. And then we'll go over the premiums and weighted averages, and then end with next steps. All premiums are now posted online as attachments to this agenda item, including state and regional pricing. So here are our recommendations. The first is to remove United Healthcare's basic plans only, due to their high and unjustified rate increases for 2027. UHC's proposed rate increase for Alliance was 23%, which was over 3 times CalPERS projection. For Harmony, our rate buildup showed no increase, while UHC proposed a 21% premium increase. Together, the proposed rate increases would have equated to an additional $167 million that CalPERS members and employers would have had to pay in premiums next year. Our second recommendation is to approve a product change for UHC's Medicare Advantage plan. This change will separate UHC's medical and pharmacy benefits, which will result in a higher reimbursements from CMS. This is the same product change that the board approved last November for Blue Shield's Medicare Advantage plan. And the third recommendation is to reduce the surcharge on the basic PPO plans by half. As you know, there has been a reserve funding shortfall for our PPO plans since 2021. That year, the fund balance fell below 90% of actuarial reserves and continued to decrease through 2023. This was mainly due to a combination of premium buydowns for plan years 2020 to 2022 and the unexpected high healthcare costs for a couple years post-COVID. After a few years of premium surcharges, we've seen great improvements in the PPO fund. The funded status increased to 81% at the end of last year, and we expect it to reach its 90% required benchmark sometime this year. Therefore, we recommend reducing the premium surcharge in the 2027 basic PPO premiums by 50%, with the goal of fully eliminating the surcharge in 2028. These 3 recommendations are incorporated into the premiums we're showing you today. Now let's look at the premiums and weighted averages for the basic plans. There are no changes to the basic premiums since June, with the exception of Blue Shield's Access Plus. Blue Shield's Access Plus premium decreased by 0.25% and now has a premium increase of 10.82%. This occurred as we determined it was the best plan for the UHC administrative transfers in an additional 2 Southern California counties, which put downward pressure on its premium. Here are the Medicare premiums. There were no changes to the Medicare premiums between June and July. This slide shows everything rolled up with the 2027 weighted average changes for each plan type and a comparison between last year's increases. The basic plan weighted average is 5.78%. The Medicare weighted average is 0.51%. And the overall program average is 4.97%, which is down slightly from what we reported in June. This year's premiums are a significant improvement on last year's and a continuation of a 3-year trend of lower year-over-year increases. These are also significantly lower than the national commercial healthcare cost trend of 9% for 2027. By approving the recommendation as written in the agenda item, your action will cover the 3 items mentioned earlier, which again are remove UHC's basic plans, approve a product change for UHC's Medicare Advantage plan, and reduce the basic PPO surcharge by 50%. Based on your approvals, we'll communicate premiums and plans to members and employers in advance of and during open enrollment. This concludes the presentation, and I'm happy to answer any questions.
I do have a question, but hold on a second. I wanted to congratulate the team on the reduction this year. This is probably one of the lowest rate increases I've ever seen in my almost 12 years. But also the fact that I think you guys deserve a round of applause because national average is 9% and we came in at 5%. So
Thank you, we appreciate that.
as always, it hurts everybody when those rates go up, and I think we all know that you guys work really, really hard to figure out ways to bring that increase down for us. So with that, I'm going to hand it over to you, or I think it's Ramon, right?
I have a question though, before.
You have a question
Yeah.
first? Okay.
Yeah, just without repeating what Teresa said, they used to say to everybody, sharpen your pencils, but now we have AI that can do
Sharpen your AI.
that can do such a much better job than pencils ever did. But it's unfortunate that we live in a society where, on a national average, premiums are outpacing cost of living adjustments. And to see that you were able to pull those numbers below that national average, again, just thank you for that work that you've done, and the team, and Don, phenomenal job, so thank you for that.
Thank you very much. It's a very strong team, and we have a very great leadership, so it's not one person doing it themselves, for sure.
I will, if I'm sorry to pile on, but it's been sort of bubbling up. I just want to thank the team. This was, when we went into this year, at some point early on, I said, this is going to be the hardest year we've probably seen since COVID, and maybe harder. There were just a number of curveballs that came in our direction, and I think the entire team saw it the same way, which is that with change comes opportunity, and there were a number of opportunities here. We have a health plan that we're bringing into our offerings that we're very excited about. That it leans into financial alignment, that is population and preventative health based. We've done, I think, a very good job of trying to mitigate, as Rob has mentioned, all of the potential disruption that comes with such a disruptive moment, and we were able to get good rates, and that is because of the work of Rob and Rob's teams, and Julia and Julia's teams, and Yesenia and Jared's teams. The other thing that we didn't mention today, which you guys did last month, is we approved this fertility benefit, which is a wonderful thing. It is something that we always wanted to do, and we're terrified of financially. And Dr. Logan and her team, Lisa, who you're going to be hearing from, negotiated what is, I think, going to be the gold standard for that benefit, and we were able to, thanks to you, extend it to our PPO members from the get-go. So that's a very exciting thing. It's great for health equity, and we're super proud about that.
Thank you. Given all the great work that was done and the words of praise that were spoken by our president and our vice chair for the health and health plans, I think I do want to continue a little bit with that. I think it's appropriate to also thank Don Moulds and his team and Rob for all the work they've done. I think besides the premiums, people have spoken about it, I think we should also mention that they were able to negotiate very favorable rates, appropriately correct rates for the Medicare Advantage plan for United Healthcare, so they'll still will be on the menu. And I think the work they've done in making sure that the PPO is stabilized, so we can continue it by lowering the surge of 50% and be eliminated fully by 2028. And Don mentioned was something I was going to say, was the family building benefit. I think is something that people will be looking to CalPERS for. So with those words, I would like to respectfully ask and feel proud to ask the board that we move forward a motion to approve the staff recommendation on the 2027 HMO and PPO plan premiums and plan design.
Okay, I have a motion by Mr. Rublicava and a second by Mr. Palkey. I have a...
No, it's after the vote.
After, okay. So I don't have any public comment. So all those in favor, say aye.
Aye.
All those opposed? And any abstentions? Hearing none, motion carries unanimously. Thank you very much, healthcare team. Yay. Ms. Walker.
So Don, I know Kaiser is opening up like in the, anyway, where it's opening. Are we going to send out a letter to the people in those zip codes to say, hey, I know it's open enrollment and they should be looking, but it's kind of like a heads up to say, hey, this is coming?
Yeah, we have the zip codes out now on our website. They the unfortunate piece of that is that there are not new zip codes this year. Kaiser had been looking at, as I think you knew, expanding zip codes out closer too. So it is available in Nevada, but the offerings in California are still back up.
Yeah, it was more than Nevada. That's where I hear from some folks that say they know they're coming, they just want to. So if we, since we have the zip codes, we can do a targeted
we're happy to do
email
that.
or letter, probably email, because I hate letters.
We could do both.
Okay.
I turned it off. So we are going to move on. Thank you very much, everybody. That was to the state employer annuitant contribution formulas and amounts and association plan premiums. And I take it it's Rob again, huh?
Yes, last one here for me. Okay, good morning again. This is an information item regarding the 2027 state employer annuitant contribution formulas and amounts and the association plan premiums. The attachments are posted online for this presentation as well. On this slide, we show the state employer annuitant types and their corresponding contribution formulas. In general, there are two groups of annuitants: basic annuitants who are enrolled in a basic health plan, and Medicare annuitants who are enrolled in a CalPERS Medicare plan. These two groups fall under different state contribution formulas based on their date of hire and bargaining unit. The 190 formula includes basic and Medicare annuitants hired prior to 2016 or 2017 and includes CSU members. This contribution amount is determined by CalPERS. The employer contribution for this formula includes 100% of the weighted average basic premium for subscribers and 90% for dependents. The 80-80 basic formula is for active annuitants hired on or after January 1st, 2016 or 17. This formula excludes CSU members and is calculated by CalHR. The employer contribution for this formula is 80% of the weighted average basic premium for subscribers, as well as 80% for dependents. Lastly, the 80-80 Medicare formula is for state Medicare annuitants hired on or after January 1st, 2016 or 17, and also excludes CSU members. The contribution amount for the Medicare formula is calculated by CalPERS. The employer contribution here is 80% of the weighted average Medicare premium for subscribers and 80% for dependents as well. On this slide, we can see the tiers of the employer health contributions for all three formulas discussed on the prior slide. The tiers are single, two-party, and family. You'll see for the 80-80 Medicare annuitants, the employer contribution actually went down as the two Kaiser Medicare Advantage plan had premium decreases and the PERS Platinum Medicare Supplement premium was flat. Now we'll briefly touch on the association plans. As a reminder, CalPERS does not administer the association plans. The associations themselves are responsible for ensuring that their premiums and benefit changes are appropriate and that the reserves are adequate. There are no benefit design changes for the association plans next year. Here are the association plans' weighted average premium changes for 2027. The basic plans have about an 8.25% increase from last year, and the Medicare plans have about 11.5% increase from last year. The next steps here are to communicate the association plan premiums to our members prior to and during open enrollment. Open enrollment starts on September 14th and ends on October 9th. The effective dates for these premiums and employer contribution amounts is January 1st, 2027. This concludes our presentation, and we're happy to take any questions.
Looks like Dawn has a question. No? Anybody have questions on this? Because this is an information item, correct?
Correct.
All right, so the board does not appear to have any questions, and I have nothing from stakeholders, so thank you very much. It was a great presentation. I had one question, hold on. I just thought it was odd, the wording of it. So both on the 190 basic Medicare annuitants, it's page 2 of 6, 80/80 and 80/80 Medicare annuitants. It says self is 100% of the single party weighted average premium. Dependents, 90% of the additional weighted average, and it says that for everyone, 80% of the additional weighted average. So you take that amount out that would be for the dependents, and then you do it that way?
It's calculated that way, yes.
Yes, okay, so that's what I wanted to know. So does that make it a different number than if they did the whole thing together?
It's based off, I think it does slightly, but it's something that I'll need to check with the team with, but it is written that way in statute, therefore we calculate it that specific way.
Okay, I think it comes to a little more if you do it that way.
Okay.
I'm not sure, but yeah, okay. I just was curious. All right, seeing no other questions, we're going to move on to clinical quality, behavioral health, driving better outcomes for our board members. And I believe it's Dr. Logan and Lisa Albers, I'm sorry. And I just want to remind everybody to speak into the mics because it's hard to hear in here.
Good morning, President Taylor and members of the board. Julia Logan, Chief Clinical Director and CalPERS team member. I'm joined today by my colleague, Dr. Lisa Albers, our Director of Clinical Policy. We're excited to be here to talk through what is near and dear to our hearts, clinical quality and behavioral health. First, I'll provide you with an update on our quality strategy and quality results for basic and Medicare. I'll then walk through an update on our primary care access strategy. Finally, Lisa will share with you some updates on our work to improve access and the quality of behavioral health services for our members. Let's review our overall quality improvement strategy. It's based on 5 strategic priorities. First, we continuously evaluate our quality alignment measure set, or QAMs, to ensure measures remain relevant for our population, are evidence-based, and align with our purchaser partners. We review the benchmarks that we require our plans to meet. While the health plans are required to hit the 66th percentile nationally to avoid any financial penalties, the 66th percentile is not our ultimate goal. Our goal is continuous improvement. We want our plans to improve every year above and beyond the 66th percentile, and we will continue to review the benchmarks as we review the measures. Second, we prioritize the identification and elimination of health disparities because we can't claim to have a high-quality health program with care that is not equitable. We're stratifying our quality measures to detect differences in outcomes between different populations, and we will utilize financial penalties to drive improved health outcomes for every member. Third, as you know, we continue to collaborate with our partners, Covered California and Medi-Cal, as well as other state partners, to create and sustain a culture of quality and equity to drive improvements in health outcomes for everyone in California. Fourth, we will leverage public reporting to drive change. We're developing a webpage right now where we will post the QAMS results so that our CalPERS members can access that information to help inform their health plan choice. Public reporting can help drive improvements in quality and equity and informs members and stakeholders of health plan performance. It promotes health plan transparency and accountability as well. And fifth, we continue to work on providing accessible and high-quality networks, primarily through a focus on advanced primary care. We have recentered primary care as the principal vehicle for our transformation to high-quality care. Decades of research support a consistent finding. Stronger primary care is associated with better health outcomes, including lower mortality, greater equity, lower cost, and improved patient experience, which is why we and our purchaser partners continue to prioritize primary care. So let's talk about our QAMS results for year one. As you'll remember, we shared overall results back in January with you, and now that results are finalized, we're sharing specific results for each health plan. As a quick reminder, our quality alignment measure set consists of 7 high-impact, evidence-based, primary care-oriented measures. On this slide, you'll see health plan-specific results for the measures which we refer to as the Big Four. These well-established measures are aligned with Covered California and Medi-Cal and significantly impact the health of a large number of our members. To orient you to this slide, each of our HMO plans listed along the left-hand column and the 4 measures outlined along the top row. The numbers in the table are the health plan's rates for those measures. Typically, the higher the number, the better the result. But I did want to flag that poor diabetes control measure in the far right-hand column is an inverse measure, where a lower rate is actually a better result. The colors, red, white, and green, indicate how well the plan did on that measure relative to the national percentiles. For rate shaded green, the plan met our goal, and for rate shaded red, the plan fell below the 25th percentile nationally and owes us the full penalty, and they must submit a QI plan. And white means they were between the 25th percentile and the 66th, so they owe us some penalty, but not the full amount. I'll walk through a plan example. That's okay. No problem. On the bottom row, WHA didn't hit our goal for childhood immunizations, so owes us a partial penalty, but hit the benchmark on the other 3 measures, so doesn't owe us for those. As we shared in January, from 2023 to 2024, we saw quite a bit of improvement in the number of plans that met the 66th percentile for both blood pressure control and colorectal cancer screening. And plans continue to do well on diabetes control for both years. Overall, the inaugural year of our QAMS program saw the vast majority of CalPERS members benefiting from improved care. For instance, about 75% of all CalPERS eligible members receive their colorectal cancer screening, which exceeds the national average. What's really remarkable and gratifying to me is that the improvements on those measures translate into hundreds of CalPERS members' lives improved or even saved. I also want to share results for our non-core measures. Our QAMS measures include maternity measures that look at prenatal and postpartum care because we know it is so important for mom and baby's health to have access to timely pregnancy care. For prenatal care, 7 of our 10 plans improved between 23 and 2024, and 5 exceeded the 66th percentile. For postpartum care, while 6 of our 10 plans improved between 23 and 24, Kaiser was the only plan that achieved our quality goals for postpartum care. Clearly, this is an area we need to work on to improve. So we've talked a lot about the numbers. I wanted to highlight what this means for plans and interventions for patients. This slide shows how much focus and resources plans have invested in the QAMS measures. For example, plans are providing direct-to-member test kits via the mail to increase colorectal cancer screening. They're providing devices to help monitor the blood sugar of members with diabetes remotely in order to better adjust their treatment, and they're ensuring pregnant members have access to doulas if desired. As importantly, plans have told us that the QAMS are driving organizational priorities and financial resources at the executive level. while measure convergence across covered California and Medi-Cal and CalPERS helped establish a unified set of priorities for health plans and providers, the addition of much more meaningful and consistently applied financial consequences increased the relevance of these measures in organizational decision-making. In other words, health plan leadership received clear, consistent signals to reprioritize investment around quality, reallocate resources, and accelerate operational changes necessary to improve performance. With more than $500 million at risk across all three purchasers, the impact of even the threat of the collective penalties was swift. Quality was no longer just a conversation for the health plan staff, but became an agenda item for executive officers, chief financial officers, and actuaries. Several plans have shared that the QAMs and similar programs turned quality into a priority and unlocked new investments and resources within the plan. Plans also created cross-disciplinary strike teams that brought together financial, contracting, and quality teams in one place to align their priorities around quality outcomes. One plan leader who I was on a panel with recently said that our aligned quality programs set a North Star for all of us that has the commitment of all levels of our leadership, from our president all the way down through the organization. It got our full attention. And this is exactly what we're hoping for to drive change for our members. Speaking of those financial incentives, this slide outlines the amount that each plan will pay back to CalPERS as a result of their performance on the QAMs in year one. The money paid to CalPERS will be applied equally across all plans to reduce member premiums. I'll remind you that we'd prefer not to collect any money from the plans because that would mean that every plan would be above the current benchmark. For the first year of the QAMs, approximately $64 million was at risk. Our plans were required to pay back a total of $7.3 million. As you can see, again, that shows that the incentives are working to drive improvement. Kaiser was the only plan that did not have any penalties due to their excellent results. This is especially great news given how many of our members Kaiser serves. So what does this all mean? Well, as I mentioned just a few minutes ago, these big incentives are driving changes in priorities and investment at the health plan level. And the improvement is already apparent in the first year of our QAMs results. What's more, most of our CalPERS members are getting care that's better than the national average. And finally, we can't improve care for our members without changing how providers deliver care. And that's being driven by the focus we and our partners have put on these important measures. In this way, we're working together to improve care for all Californians. So far today, we've spent a lot of time talking about QAMs because they're an important part of how we evaluate plan performance. But I do want to zoom out a bit. One concern I had going into this work was whether such a strong focus on QAMs might unintentionally cause plans to put all of their attention there, and whether quality in other areas might start to slip. Fortunately, that's not what we're seeing. And our oversight goes well beyond QAMs. Under our contracts, our HMO and PPO plans are required to maintain accreditation from the National Committee for Quality Assurance, or NCQA. As part of that process, plans report on more than 30 quality measures that cover a wide range of preventive care, chronic disease management, and behavioral health. Those measures are used in NCQA's overall health plan ratings, and our contracts require plans to maintain at least a 3 out of 5 rating. We think of this as our floor for quality. When we recently reviewed those measures, we did not see any concerning drop-offs or cliffs. Measures like breast cancer and cervical cancer screening, immunizations, and follow-up after hospitalization for mental illness have remained stable. So while we focus today's discussion on QAMs, it's really important to remember that we're keeping an eye on a much broader set of quality measures. And based on what we're seeing, plans are not only improving QAMs, but they're improving other quality areas as well. And that's encouraging. and it's something we'll continue to monitor closely and share that progress with you. Moving from our QAMs, I wanted to spend some time on how we measure quality in Medicare through Medicare star ratings. Medicare uses the star rating system to measure how well Medicare Advantage plans perform by scoring how well plans do in several different categories, including quality of care and customer service. Medicare assigns plans an overall star rating to summarize the plan's performance as a whole. The ratings range from 1 to 5 stars, 5 being excellent. Plans that achieve higher ratings, greater than 4 stars, receive bonus payments from CMS and preferred enrollment status, also from CMS, creating powerful incentives for quality improvement. CalPERS requires that all of our MA plans maintain a star rating of at least a 3 or above. And as you can see for the most recent star ratings results, all of our plans are meeting that threshold. When plans do fall below a 3-star rating, we have a corrective action plan process that includes close monitoring of the plan. If the plan fails to maintain a 3-star rating over successive years without improvement, they can be subject to financial penalties and possibly termination. Next slide. How our members experience their care is an important facet of quality. Clinical outcomes matter, of course, but so does whether members can access care when they need it and whether they have a positive experience with their health plan and providers. That's why our annual health plan member survey is so valuable. It helps us understand members' experiences and identify areas where we can improve access to care and the overall member experience. I've highlighted a few results on this slide, and Lisa will talk about behavioral health later in the presentation. Most members, both basic and Medicare, received an appointment for routine care as soon as it was needed, though that percentage decreased slightly between 2024 and 2025. Most members also rated their overall health care as high, though again, that percentage decreased slightly from 2024 to 2025. Finally, the majority of members described their overall health as good, very good, or excellent, similar to last year. Our site decline and results are consistent with national trends. Nationally, patient experience scores declined significantly during the pandemic era, and while some measures have stabilized, many organizations, like ours, are still working to return to pre-pandemic benchmarks. We've talked a lot about the QAMS results in the HMOs, but we're carrying this quality focus throughout all of our contracts so that our members can expect the same high quality in our HMOs, PPOs, and our pharmacy benefit manager. Later this year, we will receive QAMS results for 2025 for both HMOs and PPOs. CVS also has incentives tied to the QAMS measures for which pharmacy can have an impact, blood pressure and diabetes. CVS has $10 million at risk for the basic and Medicare populations starting in 2027. Finally, I wanted to touch on the work we're doing on hospital quality. CalPERS, along with Covered California, is partnering with Cal Healthcare Compare and many health plans on a statewide collaborative to improve the quality of care delivered in our hospitals. We partnered to form CalHQ, the California Alignment for Hospital Quality, and we're focused on improving hospital quality through aligned action together. CalHQ recently held 2 in-person meetings to focus on our initial goal of preventing healthcare-associated infections. CalPERS participated in both of these meetings and hosted the Northern California meetings at our headquarters. We're excited to be a partner in this work to improve hospital quality for our members and across the state. Shifting gears a bit, I wanted to focus on advanced primary care, a key part of our health strategy, as you know, to improve access, quality, equity, and affordability for our members. We're working with our state partners to consistently signal to health plans that primary care is our priority by aligning key contract requirements, as well as providing support and forums for discussion together. For instance, this past November, we, along with Covered California and Medi-Cal, hosted a joint meeting on increasing primary care investment for all of our health plans. We had over 30 plans across the state attend and invited national experts on primary care, as well as other state partners, to help work on actionable strategies that health plans could employ to make headway. We're also working to expand access to primary care in integrated behavioral health through virtual care options, increasing partnerships with existing federally qualified health centers, such as Shasta Community Health Center, and through our primary care clinic initiative, which I'll talk about on the next slide. We know primary care access and workforce capacity are real challenges in many parts of the state, and many of you have raised this issue as well. Members are experiencing long wait times for appointments and are turning to emergency rooms and urgent care for their primary care needs in some cases. Given this, and as Don mentioned in his opening remarks at last month's board meeting, we're in discussions with vendors experienced in operating community-based primary care clinics, with the intention of setting up our own CalPERS primary care clinics by 2027. We've talked with other employers who have their own clinics. We've visited several clinics, including one yesterday, in fact. We've done an analysis of our own claims showing where members are underusing primary care and going to the ER for primary care. And we're also launching our own access survey later this summer to better understand specific access issues our members face. Our key goals in setting up clinics for our members are to increase access to primary care, particularly in rural areas, to provide access to high-quality integrated care, and to disrupt referral patterns in certain markets that have led to high hospital and outpatient care spending. We're looking at potential clinic sites around the state, primarily for PPO members, sites with the biggest need in terms of access, with the possibility of expanding to HMO and EPO members when and where it makes sense. Next slide. Thank you. Our approach to launching primary care clinics is grounded in building a sustainable, scalable model that strengthens, not disrupts, the existing healthcare ecosystem. Our site strategy prioritizes locations where we can improve access while retaining high-quality providers and complement established provider networks rather than competing with or poaching clinicians from them. The care model we envision for our clinics is designed around integrated relationship-based primary care, one that offers coordinated specialty referrals, seamless care navigation, and same-day access to meet our members' needs. Equally important, we will hold our clinic vendors accountable for driving member engagement, ensuring that eligible members are connected to and actively utilize these clinics. As we design the model, we're intentionally designing it to be repeatable and adaptable, creating a framework that can be successfully replicated across different geographies around California and provider markets, while maintaining consistent quality and a better member experience for our members. For the past several months, we've had lots of back and forth with different clinic vendors to discuss scope of clinic development, how they would support the actual clinic sites, financial assumptions, and potential costs to us. We will present you with a vendor recommendation for approval at our September board meeting. Contract development will occur concurrently so that we can finalize this agreement shortly thereafter to move forward with implementation and a launch of a clinic in early 2027, with the potential for more clinic sites in late 2027 and 2028. With that, I'll pass it to Lisa for our behavioral health update.
Before we go there, can I ask a question?
Go ahead, Ms. Walker.
Before we moved on to behavioral health, I just wanted to ask Dr. D'Aulier, I noticed on slide 10, right, where you talked about the national, I noticed Sharp since 2023 has been on a downward slide. So have they addressed that? What are they talking about?
Yeah, that's a good observation. And we meet with each of these plans. Lisa and I and our team on a regular basis to talk about the star ratings, and the star ratings themselves are quite complex in how they grade the MA plans. There's some measures that can be difficult when a plan is first starting.
Okay.
Like our Blue Shield Medicare plan, they had a lot of members come in at once.
Right.
And the new members they didn't know so well, so it was harder to reach that high level of quality.
But then they went back up. Blue
Yeah,
Shield did,
they
but-
did go back up. We, like I said, we met with them on a regular basis. I'm not saying we caused them to go back up, but
No, I know, but just,
Yeah.
I mean, if, when you see a downward trend, I have questions like, what?
exactly, yeah.
Okay, that was just it.
I would
Oh,
also-
and then before I forget, I am very excited about our clinics. Very excited. Great job. Appreciate you guys being forward thinking about that. That is amazing.
Yeah, we're really excited about it too.
Yeah, we
We'll
should make
keep
a
you
big
posted.
splash about it when we open the first one and everything. Seriously, we have to toot our own horn sometimes. Media things and.
Big scissors. I would also
Mike?
just say about the Medicare star ratings, they've been trending down nationally for all plans due to changes in the methodology for how they calculate the star ratings. So some of it is actual services and performance related, but some of it is also the changing of the star ratings methodology.
All right, question from Mr. DeToy?
Thank you. Thank you for the report. Not that I'd ever question the data that we get from insurance companies, but is there an audit that we do
Never.
based on the benchmarks and just making sure that those are valid and not just coding?
Yes, exactly. So for our QAMS measures, we actually have contracted with a third party, the Integrated Healthcare Association, that independently calculates the rates for the plans. So there's this comparison and very thorough process. And if the plan has a concern about IHA's rate, there's a back and forth and a discussion of the methodology. And IHA gets all of the data from the health plans.
Perfect. And then is there a cross-reference for, and I don't know if there's a correlation or not, between the lower satisfaction ratings from our survey and then the lower benchmarks, or is it just, randomly
Yeah,
across the
so
board?
that member survey, it's really interesting because as I mentioned, nationally, the numbers have been going down around member experience. And I think it's probably, as with everything, multifactorial. But with our member survey, we get the lowest ratings in access. So I think we were talking about just the real access challenges that people face across the state, specifically in certain areas. And so we think that access is really driving the lower experience.
And I'm not in CalPERS health plan, but I think and I live in a major metropolitan area, and I think access is across the board for primary care, specialty. My derm appointment was a month and a half out, so I mean it's hard across the board. So
Yeah.
I appreciate all the work and the quality control metrics. Thank you.
Thank you. I think we got it.
All right, thank you. Thanks for having me. It's very nice to be here again. So we'll switch gears again and focus on behavioral health for a bit. As we've done in the past, we'll go through a summary of some prevalence and utilization trends for common behavioral health conditions, and then I'll provide an update on key findings from our annual health plan member survey related to behavioral health. And then lastly, I'll talk about some new and ongoing initiatives that we have for our behavioral health strategy to try and help get us closer to our goals. First, though, I want to talk a bit about our current overall strategy for improving behavioral health, which is rooted in the same principles that drive all of our work in health, whether it's physical health care or behavioral health care. And that's that behavioral health care should be high quality, equitable, accessible, and available to our members where and when they need it. And just as importantly, members should be aware of the behavioral health benefits that are available to them and how to access those. So to support these principles, we advocate for our members at the individual level through routine monitoring of our appeals and grievances, which sort of provide us with signals of where things might not be working for our members. At a higher level, we work with our plans to ensure member education around behavioral health benefits and how to access them. And then finally, at the state and federal level, through collaboration with other stakeholders, we promote policies that support parity of benefits as well as, of course, improved access. As we all know, access is really very key with behavioral health. And so we're looking for and trying to understand gaps in access to behavioral health through the Timely Access Survey and our health plan member survey, which we'll talk more about in a bit. So let's take a look at our updated prevalence for 3 common behavioral health conditions that drive a lot of behavioral health utilization. And prevalence, just as a quick reminder, that's the proportion of any group of people, and in this case, the basic members on the left and the Medicare members on the right, that have a given condition or diagnosis in a particular time period. So on this slide, we see the year-over-year trend for anxiety, depression, and substance use disorders between 2021 and 2025 for both the basic and Medicare members. I do want to highlight a change from our reporting of this same data in years past. This year, CalPERS actually has a different methodology for determining prevalence available to us through our data warehouse. The new method enables us to more completely capture prevalence, so we reran the rates for each of the preceding years using this new method so that everything would be consistent. The increases that we see in prevalence from year to year, they are similar and consistent with what we have reported in years past. The updated prevalence numbers, though, are more consistent with what we see reported in national data. So rates for anxiety are slightly higher in the basic population than in Medicare, while rates for both depression and substance use disorders are higher in Medicare than basic. That is also fairly consistent with national data. All 3 conditions, both for basic and Medicare, continue to show small but steady increases in prevalence, which is why we continue to prioritize access for members with these diagnoses. So we also wanted to pair that prevalence data with our utilization data. As you can see here, services for substance use disorders has stayed relatively constant. That's the bottom line on each of the graphs, basic on the left, Medicare on the right. And we have seen steady increases in utilization of services for anxiety and depression over the past 2 years, especially in the basic population, and that mirrors the small steady increases in prevalence. That's important because we know that many adults, including older adults, experience symptoms of anxiety or depression. A recent study found approximately 1 in 5, in fact. So we do want to see these utilization numbers increasing, particularly as the prevalence continues to increase. And if you're curious as to what these services are that is contained in the utilization numbers, it's a variety of things. It's outpatient therapy or counseling, it's inpatient and outpatient hospital services, it's medication treatment, and it also includes both virtual and in-person care. So the next slide focuses on virtual care or telehealth. So this shows utilization of virtual care or telehealth visits, use them interchangeably, for behavioral health for both Medicare and basic. As you can see, telehealth utilization for the Medicare population has stayed relatively constant. That's the green line on the bottom of the slide, and it's much lower than that in the basic population, which is the blue line. We saw a steady increase in the basic population utilization of virtual services between 2022 and 2024, with a slight dip then in 2025. As a part of the routine monitoring that we do with our health plans, we get data from them on outpatient behavioral health utilization, both virtual and in person. And many of the plans report that more than half and sometimes upwards of 70% of all outpatient behavioral health utilization is being conducted virtually for commercial members. This appears consistent with national trends, which show that more than 60% of all telehealth visits for any physical or behavioral health condition are for behavioral health, and that between 25 and 50% of behavioral health visits nationally are being conducted virtually. So this has obviously become a very important vehicle for the delivery of behavioral health care. So getting back to that health plan member survey, as Julia noted earlier, we conduct this on an annual basis, and we have several questions that focus on behavioral health. As she also pointed out, it's a very useful tool for us to track how members are feeling about and experiencing their health care, along with the monitoring of grievances and appeals. It all helps us to better understand what it's like for our members to get and access care, and to note where there may be concerning issues or trends that we need to address. So as you can see on the far left circle there, most of our members access counseling and treatment as soon as they needed it, and the percentage that did so increased somewhat between 2024 and 2025, which is good news. Most of our members also reported being helped by their counseling and treatment, and the percentage that reported being helped a lot increased between 2024 and 2025. And then finally, in the far right circle, you can see that 88% of our members rated their overall mental health as good, very good, or excellent, which is similar to last year's results. Additionally, we asked members about how often they've been screened for feeling sad or depressed, and that rate of screening, as reported by our members on the survey, increased between 2024 and 2025. In addition to the annual health plan member survey, we also conduct a supplemental survey every year to understand how our high needs members are experiencing their care. We include the same behavioral health questions so that we can compare responses among these groups, and it helps us better understand the differences by plan type and how the experiences of higher needs members may be differing from those of the general membership. An analysis of the behavioral health results from that supplemental survey showed that among our basic HMOs and PPOs, Kaiser in particular showed greater improvement in terms of members receiving care from a mental health provider when they needed it, and also that they were helped a lot by that care. So that was an encouraging result. While we have seen some encouraging results in our health plan member survey and the supplemental survey, we know that we still struggle with behavioral health access across all of our plans. So what have we been doing? First, we continue to update and strengthen our contract requirements around behavioral health. Our contract requirements really continue to be one of our strongest levers for improvement, as Julia demonstrated in her discussion of the QAMS results. The contract changes we've been doing include support and promotion of integrated primary care, so meaning primary care integrated with behavioral health care, and we've done that through increased primary care investment. Contract changes also include improving member communication about behavioral health services and ensuring adherence to mental health parity requirements. We also recently completed an assessment of our HMO and PPO provider directories for behavioral health because we wanted to see what that sort of first foray into trying to find a behavioral health provider is like for our members. The results showed some significant inaccuracies, despite the fact that there are existing state and federal regulations that require routine updates by the health plans. We know that inaccurate directories contribute significantly to member frustration, which is quite understandable. And they also increase members going out of network for care, which can lead to increased member costs. Across all the plans for the providers that we sampled, we found approximately 40% invalid listings. That means inaccurate or disconnected phone numbers, providers no longer in practice or no longer accepting that health plan. So we're going to be working on this aspect of our members' care with our health plans. We also continue to monitor our behavioral health networks through our review of grievances and appeals, as I mentioned. And as we've shared with you before, we're engaged in a timely access survey that is looking at members' timely access to routine therapy appointments. That's across our HMOs and our PPO. We're reviewing the preliminary results right now, and they appear consistent with what we have seen in comparable studies conducted by others across the country. In other words, the initial results are not where we'd like them to be. However, the study only looked at the traditional or brick and mortar behavioral health networks, meaning those providers that you would see in person who may also offer you a telehealth appointment, but it's assumed that at some point you would see them in person. The study did not assess the additional virtual-only networks that our plans contract with to augment the traditional networks. So we're looking to find a way to assess that other crucial part of behavioral health access because, as we talked about just a little bit ago, we know that as many as 50% or more of all outpatient therapy appointments are occurring virtually. We continue to work in collaboration with our purchaser partners as well as state partners on measuring behavioral health care investment with the intent of eventually requiring a benchmark as we've done with primary care investment. And then finally, we're very excited about some work we've just started with some consultants to conduct a deep dive into prior authorization practices across all of our health plans and across all services, including those for behavioral health. We know that sometimes utilization management practices can be a barrier to care, and we particularly would like to know if any of these, including prior authorization, are a potential barrier to behavioral health access for our members. So given how important behavioral health access is to all of us, particularly our members, in addition to the activities I just described, We have several areas of focus for the upcoming year. First, as I mentioned in the last slide, we're evaluating barriers to access through multiple methods, including our ongoing survey work and that prior authorization review. We're also launching an additional access survey in access-challenged areas served by the PPO to understand barriers to care and opportunities to address those barriers from our members' perspective. That survey will contain a question on mental health services, as well as questions that ask about very specific barriers that members are experiencing. And we're going to be engaging our health plans to educate and promote supplemental virtual services to help close some of these access gaps. As you heard from Julia, we are committed to increasing access to advanced primary care, a cornerstone of which is the integration of behavioral health care. There's probably no better way to improve behavioral health access than increased integration of behavioral health services into the primary care setting through team-based care and warm handoffs to behavioral health providers that can support the member, as well as support the primary care provider in treatment of behavioral health conditions. Our upcoming clinic initiative will exemplify that integrated care model. And several of our health plans continue to increase the adoption of the collaborative care model, which is a very specific model of integrated behavioral health care into primary care for common behavioral health conditions. We'll also be working with our plans and partners to improve our behavioral health provider directories. As I said, there are existing regulations that mandate the routine updating of these directories, but it's a very challenging process. And obviously, our recent assessment shows that more work is needed to make that first step in finding a behavioral health provider less frustrating for our members. And then finally, we're working on the development of a behavioral health dashboard, an internal dashboard, to monitor utilization, cost, quality, and spend, among other things. We think this will be a useful tool to help routinely track our behavioral health care and also enable us to have more productive conversations with our health plans. So we remain committed to improving the quality, access, and experience of behavioral health care for our members and look forward to progress in the year ahead. Thank you. Happy to take questions or feedback.
So I'm going to congratulate you guys on listening to our members, because I got a lot of complaints, and I had the issue myself of not being able to, that list that we get from whatever healthcare provider is way out of date. They were providing names that were mostly, for me, it was like child therapy, wasn't adult therapy. And then I heard a lot about wait times. But it's also, I don't know if we're getting more therapists. I know there's a difficulty in finding therapists, and there's a finite amount in every area. So have we worked on that as well?
Yeah, your comments are so familiar for me, for everyone. I think we know. A couple of things. I would say the provider directories, yeah, the results of that assessment were a little bit surprising to us, and that feels like low-hanging fruit that we really need to try and focus on. And our health plans are already doing a lot of this work. They've recognized it too. So several health plans have started to conduct routine monthly audits of their provider directories to try and weed out the inaccuracies. And they will call the provider offices, they will verify the numbers are working, that the numbers are accurate, the location, that they're still in network, all of those things. So that's a good step. And they're also going through the effort of removing providers from the directories that haven't submitted a claim in 2 years, for instance, to really try and cut down on some of that inaccuracy. In terms of the workforce, that remains a challenge, just like in primary care, if not more so. That's one of the reasons that so many of our health plans are utilizing these supplemental virtual networks to try and relieve some of that access backup due to workforce issues. But it does continue to be challenging.
So I appreciate all of that. That's helpful. Did you guys, are the health plans just not just finding out if they're still in network and stuff, but are they identifying what kind of therapist they are? Because that is very helpful, because I'm not going to call a child therapist if, No,
that's a great question. There's been a lot of work and discussion on how it is we can make the directories more useful, and some are starting to do that, to put specialties along with the provider's name and demographic information, what it is that they have particular training in, what they specialize in, what the predominant, sort of group of conditions that they treat. And there is also an effort to include, as I said, demographic information in the provider directories, because we know that, people prefer providers that, reflect who they feel they are. And so if I am looking for, an LGBTQ plus therapist, because that is a group I identify with, I'm likely going to have a more successful provider relationship if I can find that person. So it's not universal at this point, but it is definitely ongoing work to include that information.
Okay. Julia?
Oh, just a comment. Obviously workforce is a huge challenge, and that's, Lisa was talking about the importance of integrating behavioral health into primary care. And just to underscore that, it is so important. About half of primary care visits involve a behavioral health component. People
really?
come in all the time with knee pain, but actually they have, depression or anxiety. So it's really important to educate primary care providers to make sure that there's access to behavioral health at the clinic. And that's one thing that we're working on with the clinic project, is making sure that we have that ready access to behavioral health so that a primary care clinician can make a warm handoff to a behavioral health specialist, just to make it as integrated and seamless as possible.
That would be really awesome. So that was a good transition. I just want to make sure that we're not loading our primary care physicians with too much work, because they are already, I know they work really hard, and they work early all the way to late just to make sure they chart and all that stuff. So that chases more doctors away if we're loading them with more stuff. But if we're getting more behavioral health therapists, or we're using the virtual model instead, which is not as personable, I guess, because you're online all the time, but a lot of people really like that. So I'm impressed with that. What I wanted to ask you, Julia, about the advancing the primary care access, and you're looking at doing this actually to launch in early 2027? Really?
That is our bold goal, yes. We realize that that's coming up quickly. We've talked with some of these clinic vendors about co-locating at first, potentially working with another entity who already has a clinic set up to allow our patients to come into that clinic. And then over the course of 2027, potentially, but having an existing CalPERS specific clinic.
Okay, and I love that. I love that idea, because anything to alleviate I think I called to go in because I hurt my neck, and my doctor's never available. So I always have to go in and see whoever's available, right? So, and to make an appointment with your primary care physician, it's about 3 months out. So
yeah, the clinic Rob and I visited a clinic yesterday, and the provider in that clinic had been there for 6 years. And she knew the community, she knew kind of the patients and the flavor of what was going on in that community, and had ready same-day access at the same time. So we're looking for a model that will accommodate that long-term relationship between patients and provider, and making sure that those patients have access when they need it.
And your target point for where these are going to be first are rural areas? That's where you're targeting first?
Yes.
Okay.
Rural areas with a high density of PPO members.
Got it. Oh, that's going to be awesome.
Yeah.
That's going to be awesome. All right. Thank you, you guys. I see Yvonne's microphone.
Hi, thank you. On slide 19, when you talked about the different buckets we're looking at, I was just wondering, for the Medicare, it's going up on the substance use, and so what is there a particular thing that they're using? I'm assuming substance use means abuse, not just substance use, right? And so is there a particular thing for like seniors that we're like on now?
Yes, I think it's primarily due to alcohol use disorder. That's the most
okay.
common
That
substance I
makes
have seen
sense.
reviewed when looking at the differences between older adults and younger adults.
Well, yeah, because they got different stuff now.
Yeah. And I think also it mirrors the rise in depression, and a lot of it to do with isolation and loneliness. And, I think it's an area where it falls through the cracks,
Right.
mental health conditions for seniors. And so this is definitely something that is becoming more of a priority for us. We're becoming more of aware on and need to incorporate into those meetings that we routinely have with our Medicare Advantage plans about what we're doing to support these members.
Okay. And then I don't know, we might have it up on the website. I haven't looked, so I'm just going to ask. Do we have like a little video? So you're looking for a mental health professional. Here's what, here are the things you should consider. And just because you get assigned one doesn't mean that's who you stay with, because they might not be like for you. I had one that was way too happy clappy, and I was like, oh, Lord have mercy. We are not going to fit. So, I think that's helpful, especially if you're just getting into getting behavioral health and, dealing with things, because comfort is the first thing, right, that you're looking for. So I think it would be nice to kind of have a, things to look for kind of thing.
We don't have something exactly like that. I think it's a great idea. I think a lot of people who have not previously used, for instance, a therapist, don't understand you might have to try a couple,
Right.
which is an additional challenge because it's hard enough to find the first one, until you have that connection.
And
that
it's
is gonna
okay,
help you.
right?
It
It's
is
not, you're not
absolutely
saying
okay.
anything bad, you're just saying, you're not for me.
Yeah, that's right. It
Right.
takes time to find one. No, it's a great
Right.
idea.
Yeah, and then just FYI, on the telehealth, right? So Sutter has a problem. It's small, but with telehealth, and so I've been working through their IT thing, but this is not just a me problem, so that's why I'm mentioning it, that we cannot access, we can get on telehealth, but then you don't get to see the people. There's some glitch or something that they have not been able to, so maybe if you guys talk to them too, because like I said, it's not just a me and talking to their IT person, it's still,
Okay. Thank you for letting me know. I'm talking to them tomorrow, so be on the agenda. Thanks.
Oh, wait, but I love Sutter, just so we're clear.
Make sure that's clear.
Mr. Rublikava?
Thank you, Ms. President. Thank you for the presentation, both Dr. Logan and Dr. Albers. I want to go back to the quality measures. I noticed on slide number 4, in general, I would, I support the whole thing you're doing about promoting primary care, and in particularly, and also the quality alignment measure set. But I always assume that the integrated system would always be better access to primary care and deal with some of these measures. So I was surprised that, in general, that's true, but Health de Salud de Mas, they don't have any of the green. They're not at 66th percentile on any of the screenings. So is that a function of the utilization, the population, or what discussions have you had with them?
Yeah, and we were concerned about that too, that Saludi Moss was generally lower than other plans. That's, again, multifactorial. Saludi Moss, as you know, crosses 2 countries.
Right.
And the care that members get in the U.S. versus Mexico, the communication doesn't always work as intended. And so the data doesn't flow very well. So part of Saludi Moss's issue may be more of the data quality rather than the actual quality of the care. So that's one thing that we're working with our third-party IHA to help with the data quality to improve those results in the next year. I suspect that next year the rates will be better.
Looking forward to the next report then. I also want to note that it's good that Kaiser hit all the benchmarks, so that's very good. Now going to behavioral health, is there a quality alignment measure set for behavioral health?
It's a great question, thank you. So the quality alignment measure set consists of actually 7 measures. We highlight these, what we call the big 4, because they have such a huge impact on the health of our members, and because it's where we have the strongest overlap with our purchaser partners, Cover California and Medi-Cal. But actually, we do have behavioral health measures on the QAMs. One of them is depression screening and follow-up. The health plans have been reporting on it. We're not yet holding them to the benchmark because there's been some issues reporting on this measure. It's more difficult for the plans to get the results of the behavioral health screening and demonstrate that it's happened. And so it's not just our plans or here in California, it's a national issue. And so it's getting a little bit better, but it hasn't been to the point yet where we felt comfortable holding them to the benchmark, but we're getting the data and we're moving forward with that measure. There's a bit of a dearth nationally in behavioral health measures for quality, and so we are talking with our purchaser partners as well as folks like IHA and NCQA to try and figure out what might be additional behavioral health measures that we might want to adopt in the future.
Thank you. And the other thing about behavioral health, sometimes it's not diagnosed or people don't want to admit it. So I applaud CalPERS. For a couple of years ago, we started this integration where through primary care, they do the first assessment, they can do referrals. So in response to a question, they mentioned about sometimes it's prevalent comorbidities, I think, right? When you have depression, but it's because something else, you have chronic disease or something. Have we seen, I wasn't clear, any of these measurements or reports, do we have anything to see that we are being successful in that integration of the care model, or there's a screening on behavioral health?
Yeah, the health plan member survey, as Lisa mentioned, has a question around screening in primary care for depression, and that's one measure in that survey that's going up, is that more people are being screened in primary care settings for depression and anxiety. So that's one marker, and we do ask our plans to report on how they're integrating behavioral health and primary care, so we get regular reports. We talk about it in our meetings with health plans as well.
And I also echo the comment made by others that access has to be a priority. I know there's a lack of providers in this field, and the directory is just one problem, but there's actual lack of staffing. So thank you for the presentation. I really appreciate it. Thank you, Madam President.
Certainly. I think that is all our questions from the board, and I don't have any public comments. So with that, we're going to take a break. It's 10:06. I'm going to take us to 10:25, and we're running a little early. We'll be back for contracting agency health regions at 10:25. So go get you some coffee and water. It is 25 after. We had a little extra 4-minute break. There's Dawn. I was waiting for Dawn. Can I get the board to come over, please? Thank you, everybody. So, welcome back. Oh, okay. We're going to start with a statement, and then I'm going to introduce you guys. So, Ms. Gallegos, go ahead.
Yes, am I in? Yes, thank you. Consistent with California Code Regulations Title II, Section 18707, the controller was recused from and did not participate in the first 2 agenda items because of financial interest in United Healthcare. Thank you.
Thank you, Ms. Gallegos. So now we're opening this session up to contracting agency health regions, modeling and stakeholder outreach with Don Moulds, our Chief Health Director, Health Policy and Benefits, Yesenia Croft, CalPERS Chief Health Account Management Division, and Justin Ouellette, CalPERS Actuarial Senior Analyst. So take it away, Don.
Great, thank you, and good morning still, I think. This item focuses on CalPERS regions for our public agency and school district health employers. CalPERS uses regional pricing to keep our benefits competitive. When CalPERS regions accurately reflect regional price variation, CalPERS can be competitive in every market in California. When they don't, CalPERS is only competitive in select markets, typically those that are high cost. This imbalance harms our recruitment and retention efforts, particularly in low-cost markets like Southern California. Ultimately, it also raises premiums for everyone. We've been looking at this issue since last summer and first brought it to the board's attention back in January. The analysis you're going to see today shows that CalPERS current regions need a modest but critical makeover. We're going to walk you through the analysis that led to that conclusion, and we are going to share potential options that we believe address the needed fixes. So with that, I'm going to turn it over to Yesenia and then Justin to go into detail.
Thank you. Good morning, Madam President and members of the board. Yesenia Croft, CalPERS team member. I'm going to provide background information about regions and go into a little more detail about the current challenges we are facing in regional costs and pricing. I'm also going to share key takeaways from a survey of employers that was conducted in April. Justin Ouellette from the Actuarial Office is going to share our modeling analysis, and then I'll conclude with next steps. As a reminder, we will bring you a recommendation for action in November, and any regional changes will take effect in 2028. As background, regions are a grouping of counties and/or zip codes in a geographic area where healthcare costs are comparable. Having regions allows CalPERS to price premiums closer to the actual cost of healthcare in the area. CalPERS first introduced regional pricing in 2005, and we've had 3 different models ranging from 3 to 5 regions over the past 20 years. The last time regions were evaluated was in 2018, leading to the 3-region model we have today. Region 1 is the largest region and covers Northern California, extending from the top of the state to just north of Fresno. Region 2 includes Southern Central California, as well as San Diego and Imperial counties. Region 3 is comprised of Los Angeles, Riverside, and San Bernardino counties. Regions may be contiguous or non-contiguous. Contiguous regions are a collection of counties all connected to each other. However, sometimes counties with similar market costs are not necessarily next to each other, and the region is more fragmented. This is called a non-contiguous region. CalPERS has historically had 1 or 2 non-contiguous regions. Regional pricing applies to public agencies and school contracting employers only, with all state members paying a single statewide rate. Regions also only applies to 45%, or just over 500,000 members enrolled in basic plans only. We do not price Medicare plans based on regions. Our public agency and school Medicare enrollees pay the same rate as state members. And as an example of regional pricing, here we show the 2026 rates for an individual in Blue Shield Access Plus HMO. The premiums for all state members is $1,088. But for our public agency and school members in Region 1 in the north, the premium is $1,301. Region 2 is at $1,052, and Region 3 is at $917. Let's look at the current challenges we are facing. As we've mentioned before, costs in different markets shift over time, and through our analysis, we see significant cost variations within the current 3 regions model. In fact, today, only 46% of public agencies and school members are paying within 5% of the actual cost of care in their county. This misalignment makes CalPERS premiums more appealing in high-cost areas of the state and less competitive in low-cost areas. From 2021 to 2025, CalPERS gained roughly 26,000 new public agencies and school members, with 60% residing in Region 1. Meanwhile, we lost an average of about 9,000 each year due to agency terminations, with nearly 80% of those losses occurring in Regions 2 and 3. Furthermore, as we shared in January, average medical costs of these members are rising faster than those of the state members, which ultimately drives up our overall premiums. And as we've discussed over time, this dynamic will impact stability and the sustainability of the program if premiums drift further out of sync from actual healthcare costs. This map shows you how healthcare costs and agency enrollment are distributed across the state. On the right, we show a county cost map based on the data from 2022 through 2024. We will be updating this map using 2023 through 2025 data, as we will soon have the 2025 claims run out data, and that should be happening later this summer. But as you can see here, the highest cost counties are concentrated in Region 1, which also has the most significant cost variations. Region 1 is almost entirely shades of red, though as you can see, it does vary from dark red to pink. And on the left, we have agency concentration. Region 1 is home to over 600 public agencies and schools, more than Region 2 and 3 combined. So we see that most of our agencies are in our most costly regions, concentrated in the Sacramento and the Bay Area. So with that backdrop, let's transition to the employer survey on regions we conducted in April, and I'll share some key takeaways from that survey. We cast a wide net when sending out the survey, inviting 4,800 contacts to provide input. And we received responses from about 20% of our contracting agencies. We received responses from agencies of all sizes, representing a significant number from special districts and cities. And in addition, 73% reported that they are decision makers or advisors to decision makers related to health benefits. The survey revealed employers' views on a handful of topics, as well as key preferences when it comes to CalPERS regions. Approximately 23% of the respondents felt their current region accurately reflected the true cost of care, while 35% did not. And when sharing their views on how competitive CalPERS premiums are compared to similar options in their area, 61% felt we were slightly to very competitive, while 11% stated we were not competitive. And separately, when asked about the geography of the regions, there was a higher preference for contiguous regions. And lastly, we also obtained their input on their perceived administrative complexities associated with increasing the number of regions. So regarding the potential administrative challenges, we wanted to better understand what complexities employers might face were regions to change. And some of these administrative challenges are one-time implementation related, while others are going to be ongoing. The top 3 challenges they expressed concerns about were more time fielding fielding their employee questions about premiums and coverages, communicating the changes to their employees, and then increased complexity around their payroll and benefit administration. So here are the key takeaways from this survey. Premium price and affordability is of top concern. Respondents expressed a moderate knowledge of how regions are set and expressed a slight preference over contiguous regions. They shared concern about various administrative challenges, as I just highlighted. And we took the key areas of importance of our employers to be price, contiguity, and administrative complexity. And we incorporated these 3 items into the scenarios that we will be presenting to you today. And I'll now turn it over to Justin.
Thanks, Yesenia. Good morning, Madam President and members of the board. Justin Ouellette, CalPERS team member from the Actuarial Office. As mentioned earlier, CalPERS last reviewed the regions in 2018. Since then, healthcare costs in California have increased significantly, driven by the many reasons we often discuss with the board. But they've not increased uniformly. Some areas have seen much more significant increases than others. CalPERS' current 3-region model and its pricing differences no longer appropriately represent healthcare cost variation across the state. Because healthcare costs have shifted over time, there are larger cost variations within each region. As Yesenia mentioned, this pushes CalPERS' regional premiums further away from the actual costs of healthcare for a large proportion of our members. I'm going to talk about the approach we used to measure regional costs and perform regional modeling, and then I will share 3 scenarios that the team collaborated on, along with key metrics to better understand each scenario. There were 3 key activities to our regional modeling approach. First, we conducted a CalPERS-specific county cost of care study. This study aimed to understand the total cost of healthcare on both a county-specific and statewide level, and this served as the basic building block for the regional evaluation. We then created a CalPERS custom region models to evaluate a variety of different ways that we might group counties into regions. Last, we evaluated the regional scenarios based on 3 key priorities: improving the healthcare cost alignment, minimizing member disruption and premium impacts, and minimizing the administrative complexity for our contracted agencies. In the next few slides, I'm going to describe how we went about these activities and then walk you through 3 region scenarios for your consideration and feedback. Let's start with the County Cost Index. We performed a cost of care study to determine the total cost of healthcare on both the county-specific and statewide level. This index served as the basic building block for the regional evaluation. We started by evaluating county-level medical expenditures on a per member per month basis, utilizing 3 years of historical claims from 2022 to 2024. We used a 3-year average to smooth year-over-year claims fluctuations, particularly for low enrollment counties. We applied a few key adjustments to the county-level per member per month medical costs. First, we adjusted for catastrophic, high-cost outliers. For instance, a single organ transplant or cell and gene therapy case can cause multi-million-dollar expenditures, which could heavily skew the county's average cost profile. Secondly, we accounted for member health risk to have a fair healthcare costs comparison between counties. Because different counties have fundamentally different populations, raw healthcare data would have been an inaccurate representation of the overall picture of what healthcare costs look like. Additionally, several rural counties have small enrollments of fewer than 200 members, but not all of these counties had volatile claims experience during the years of the study. For low enrollment counties that had a volatile claims experience, we analyzed members' medical travel patterns from neighboring counties and determined where they received care from neighboring counties that had credible medical data. This information was used to balance low enrollment, high volatility county costs for an overall more accurate picture. The final adjusted medical costs by county were then compared to the statewide average to calculate each county's county cost index. The county cost index is mapped out in the heat map Yesenia discussed, which visually identified the county cost variations and is also presented here. Kaiser data was excluded from this study. As a fully integrated healthcare system, Kaiser's costs and pricing are different from other carriers, and they are insulated from the geographic and enrollment dynamics that other carriers face. This has been our standard practice in modeling and recommending regions. After we established the healthcare cost profile for each county, we then leveraged those profiles to construct our regional model. This modeling allowed us to use the county cost index data along with the public agency and schools membership to group the 58 counties into various regional scenarios. For each scenario, the model produced a matrix of indicators that we used to evaluate the changes compared to the status quo. A primary indicator is the healthcare cost alignment, which reflected the percentage of members whose county costs were within 5% of the corresponding regional costs. A higher alignment percentage indicated that the regional premiums more accurately mirrored local healthcare costs. Additionally, the model tracked member impacts, including percentage of members estimated to experience varying degrees of premium increases or decreases. In the final step, the team reviewed the model outputs to determine which region scenarios met the key priorities we outlined. There are many ways to group the counties into regions. The model generated more than 8,000 possible scenarios, ranging from the most to the least number of regions, ranging from the most to least contiguous regional grouping. In reviewing these options, our team considered several key factors. The poor alignment between our current regions and actual costs is causing enrollment shifts across our public agencies and schools, which is pushing up overall average medical costs. Most employers have a stated preference for contiguous regions. One important reason for this is that employers often have employees in contiguous counties, so contiguous regions reduces the possibility that a single employer will have to grapple with multiple sets of premiums. With fewer regions, there are more covered lives per region, making costs less volatile year to year and administration less burdensome. However, a smaller number of regions, total regions, creates large cost differences within each region. We reviewed various models and determined scenarios with 8 or more regions yielded diminishing returns to cost alignment at the expense of greater impact to members and employers. Fewer than 6 regions, on the other hand, did not move cost of care alignment enough. Through our evaluation and review of the pros and cons of each scenario, we identified 3 regional scenarios that are illustrative of the trade-offs mentioned here. Scenario A is a 6-region model based on cost. Let me first orient you to all of the information on the slide. On the left-hand side, you see the map of California with reference to the number of regions based on the color of the county. As you can see, this is a highly non-contiguous model since it is cost-based. So you will see a region like the orange Region 3 spread across 5 non-contiguous counties. On the right-hand side, you will see the gauge that shows you how closely this scenario aligns to the actual cost of care. In this case, it is 95%. Right under the gauge is the percentage of members that are estimated to have increases or decreases in premiums given this scenario. Then right below is a table that illustrates the number of those members estimated to have a premium increase or a decrease by a range. For example, you can see that there are 86,200 members estimated to have an increase of up to 5% and 116,400 members estimated to have a decrease of up to 5%. And then finally, there is a note on the level of administrative complexity that is shown as high for this scenario due to the highly non-contiguous nature. Scenario B is a more contiguous regional model, as you can see by the map. This scenario represents more of a balance compared to scenario A. As a trade-off for keeping the map mostly contiguous, the overall cost alignment is 78%, and the member and premium impact is reduced due to that alignment difference. For example, the number of members estimated to have a premium increase of more than 15% drops from 1,900 in scenario A to 700 in scenario B. There is one non-contiguous county in this model, Santa Barbara. It's aligned with Region 1 in dark green since Santa Barbara's costs are more closely aligned with those other counties. It could not be grouped with a contiguous region without undermining the alignment to the cost of care. Finally, the administrative complexity is ranked medium since it has more than the 3 regions we have today, but is still highly contiguous. Scenario C is a 7-region model based on Scenario B with one change. We split out Ventura, Los Angeles, Orange, San Diego, Imperial, and Riverside into an additional region. This change brings the cost of care alignment up to 85%, with a similar level of premium impact and administrative burden as Scenario B. Scenario C is probably the best mix of administrative simplicity, low disruption, and alignment to actual prices. In Scenario C, there is a significant increase in the cost of healthcare alignment from the 46% we have currently to 85%. It is the scenario with the lowest number of members impacted with premium increases. It is the scenario with the highest number of members with a premium decrease, and it is a highly contiguous model. I will turn it over to Yesenia to talk through the next steps and look forward to answering any questions you may have. Thank you.
Thanks, Justin. Over the next 4 months, we have several activities planned. First, we have an employer webinar scheduled for August 6th, and this week we will be sending out invitations to our contracting agencies and schools, encouraging them to attend and participate by asking questions. During this webinar, we will be presenting the scenarios we shared with you today. We will also connect with our contracting employers through the Employer Leadership Dialogues, which start in August and run through October, as well as at the Employer Education Forum in November. We will share updates with our members through the various stakeholder meetings scheduled this year. In September, we will bring refined scenarios to the Pension and Health Benefits Committee, incorporating your feedback from today. And in November, we will provide our recommendation and request board action. Any new region models you adopt will take effect in January 1 of 2028. That concludes our presentation, and we look forward to your feedback and questions. Thank you.
Seeing questions, thank you very much. I know this is a tough thing to do. We've gone through it before. I don't know if we have too many new members that don't remember that, but I think we went from a lot of regions down to the 3 regions to simplify it. I noticed it looks like San Francisco Bay Area, Monterey looks like it's all broken out in its own region. Because isn't San Francisco like high priced? Or not too high priced compared to Monterey? I'm trying to see who these cities are in my mind. Yeah, I don't know. And then 3, it looks like it's partially us, YOLO. Is that correct? Does that sound about right? Yesenia's having any trouble? Anybody? Justin? By the way, Justin, great presentation. Sacramento.
Yeah. Oh, thank you. Let me pull it up here. I gotcha. Yeah. Apologies.
No problem. I'm the one that doesn't know my geography of California.
Sacramento is the bottom left corner of Region 2.
Of Region 2?
Correct.
Ooh. Okay, so that makes us a little more high price because we're kind of in with some rural areas. Is that correct?
Let me pull up the CCI map. Let's see.
Do we have a map that shows? Nope, we don't.
We do. Maybe I'll go to the one that has the. Oh, there we go.
There it is.
It is on the lower end, but closely aligned with Placer and Lassen.
Yeah, it looks like if we're there, then we got Placer, maybe El Dorado, Sierra, Butte, Plumas. So everything over here in Lassen, that's rural, correct?
It is.
And I know our prices because we have 4 hospitals, so it's kind of
Right.
collusionary. I didn't say that out loud, sorry.
One of the things to note is the more members you have in a particular county of a region, the more influence their cost has on the overall regional grouping. So Sacramento, being a hub of public agency members, has a greater influence on what that overall cost structure would be like for Region 2.
Okay. And then I'm going to go back real quick to, let me get there. Oops. Okay, so 7, Region 3 then is, looks like San Francisco. Yeah, so it's kind of that mid-region there. You know, you were right. You had it on the right map. And then how come, what is that dark green down under Region 5 that belongs to Region 1 now?
That's Santa Barbara.
That's Santa Barbara, okay. And that's because, I know you guys mentioned that it's more like cost, correct?
Santa Barbara has been historically a very high-cost region.
Okay, okay. Those were just my questions. I'm trying to figure out where everything is. And this is sort of what your preference is the C.
We at this point, what we wanted to do was, so as Justin mentioned, he looked at about 8,000 different possibilities. So he modeled them all out, and we spent a lot of time looking through them, weighing them relative to the priorities that the team laid out, administrative complexity or simplicity, contiguity, cost alignment, et cetera. These were the 3 that we thought were representative of approaches. So the first one is if you throw contiguity out the window and just go straight price, you have a very high correlation between actual price and regional price, so 95%, which is almost a perfect match. But administratively, it is more complex. We looked at a smaller number of regions in the 6-region scenario, and then our where we are at the moment is would be a very tentative recommendation for the option C, which is slightly more regions, higher cost alignment with actual costs. But one of the things that we wanted to do was take these to you to get feedback. We're going to be taking them to employers and to members, doing sort of a part 2 of the roadshow and getting feedback there. And we will learn things, because every step of this, we have learned things. There are going to be things that make this more complex, potentially more complex than another option, and we will take that back and integrate it and bring you it could be exactly the same set of recommendations, or same set of sort of narrowed options with the same recommendation. It could look different. Just knowing historically, it will probably be a little bit different after we go through that process.
Okay, so I appreciate this. This is, so I would think then it would be, besides the complexity of scenario A, that looks like your best bet, but it looks like it would be lots of questions from the people. Why am I in with a bunch of these folks? Unless when you roll it out, that's not a problem because they're looking at the costs as well. I don't know. And if the cost alignment's 95%, that looks good to me. And it has less premium increase or decrease for our members, even though the less complex one would be C. I don't know, the other one.
It has, option A has slightly more folks who would see small numbers in all of these scenarios, but more that would see the highest level, the more than 15% increase.
Yeah.
It does come the closest to achieving perfect alignment with actual costs. It is administratively complex. I mean, one of the things that we will hear when we take these out to employers and to members is the practical effects of all of these. I anticipate that we will hear the most probably from this scenario.
So, and I would suggest one of the things we run into all the time is the people work in one county and live in another county, and so if they're not together, that's going to be problematic.
That's exactly why we were migrating towards contiguous options. Yeah.
So it's bad enough when they work on the edge of California and they have to go into Nevada, but if you're in your own state and you're across a county line and you can't get care, that's an issue. So.
Yeah.
Okay, that's my suggestions. I'm looking at also C as our best one. Ramon, go ahead. You were first, and then Kevin. I'm sorry, and then Michael. It's Melissa? Okay, sorry. Looks like it's sitting right in front of Michael from down here. All right, so Ramon, go ahead.
Thank you, Madam President, and thank you for the presentation, and thank you for doing this work. It is needed. I can tell by the results. I had a couple questions. One of the charts shows the agency concentration, and the other one shows cost. But as far as covered members, covered lives, is that mostly in the what is Region 2 and 3 now, or Region 3? Because I know we represent 500, and I guess the question is the 500,000. Is that like total lives, or is it just the number of agency workers, or what does that number represent?
So the number on the slide represents the agency count, not the total covered lives.
Right, but I need to know, my question was, my question is, on the 500,000, 5,511,000, 500,000 people, are those employees of the agencies, or their covered lives, meaning their subscriber and their families?
That's total covered lives, yes.
Okay, and where are they distributed? Is it mostly in the Southern California?
We have, so in Region 1, we have, counting basic and Medicare, we have 347,000 covered lives in Region 1. In Region 2, about 78,000. In Region 3, 198,000.
Okay. Thank you for that. Then the second question is, I noticed one thing that I've gotten questions about is Ventura County, because they want to be in a lower price region. And now I noticed that in one of the scenarios, Ventura County and Orange County are in the same region. Because that's scenario A. But in scenario B and scenario C, Ventura County and Orange County are all continuous with what used to be Region 3. So that's a function, just to understand, of the alignment with cost of care more than anything else, correct? Okay, thank you. I saw Don nodded his head.
Yeah,
so
yeah.
Sorry, we should, for people who are listening, yes, that's correct.
Okay, thank you. The one that I guess I'm surprised, but if you could explain, Imperial County, it's not very rich in either population, agencies, or in access to medical care, I think, but yet it's So is there a relationship between cost and access? I mean, I'm just surprised that they're in scenario C, scenario B, actually all scenarios, they're included in the broader southern region, so.
So
Can
that's,
you explain that?
That's an interesting question.
Yes,
I-
interesting,
well,
because you
it's-
would think
it's
San Diego
actually-
would be, but it's not.
It's an interesting observation. So the short answer is yes, we tend to find that, that more rural counties tend to be higher cost. A lot of that reason is that there's less competition in those areas, so there tends to be one hospital or a single medical group, and so there isn't price competition, and providers are in a position to charge higher prices. We do not see that uniformly. We tend to see that much less in the more rural parts of Southern California than we do in Northern California. There are a bunch of different reasons for that, and we can kind of go into more of the details on a micro level about, say, Imperial if you're interested in a future meeting, but in short, they are proximate. One of the reasons is they are proximate to low-cost regions.
Yes.
So there are low-cost options. One of the things that we've been looking hard at, Justin alluded to this, is migration patterns. So people don't always go to the provider down the street or the hospital a mile away. Sometimes they go further for care. And for people who are going to some of these other places, in Southern California, those are much lower cost options, and so the pricing in some of those more rural areas comes closer to the pricing in the more suburban and urban areas. That's the short answer. There's some more complexity to it than that, but in essence that. It's much harder to shop in Northern California than in Southern California. And the other thing is that when you're moving, the folks we talk to in some of the northern counties who come down to Sacramento or the Bay Area for care, so we talk to a lot of people up in some of those northern counties who see specialists at UC Davis or at Stanford. Those are higher cost institutions than the ones that they would be traveling to in Southern California.
No, I do want to thank you for the answer. I do want to pursue this later offline because, in general, what you said is correct, but it seems to reinforce my question. But on the migration or because San Diego, looking at scenario A, San Diego County, like Ventura County, tend to be higher cost. They don't have the same alignment of care as, say, Los Angeles County or Los Angeles County, Orange County. But in that scenario, Imperial is it's a good thing, but I am surprised. I just want to hear it because if they migrate, they'll go to San Diego County, which tends to be more expensive. So it's just surprising to me.
Yeah,
I'm not going to pursue it. I just want to say it's just surprising.
No, it's a good observation, and just a very short answer to that is, it is more expensive than some of its neighbors, but it is considerably lower in cost than the neighboring counties to the rural north.
That's the answer.
Yeah.
Okay, thank you. I appreciate it. I do want to study a little bit more before I make any preference, but we do have another presentation coming our next meeting, so I can't wait.
June?
Thank you. November. Thank you very much.
Oh, next meeting. I thought you said next week. I was like,
No.
what?
November. It's in November, right? Correct?
September.
Yes. September. Thank you.
Melissa?
Thank you. Thank you for the presentation. I have just a couple questions. And if I understand this correct, I apologize if it was really covered and I missed it. But if this would take effect in 2028 and the numbers, like if we were looking at scenario C, the numbers show that some members would see between, above a 5% increase, some of them above a 15% increase based on the regional restructuring alone. So does that include the normal annual premium trend increases that we'd expect? So essentially, at best case scenario, some members are seeing more than a 25% increase by 2028, or is this including or assuming the standard yearly increases?
This would not factor in year-over-year increases in the cost of healthcare, so it would be additive, which is one of the reasons that we're paying a lot of attention to mitigating that as much as possible.
Okay, thank you. That's really hard to hear. So then also in all three scenarios, the Bay Area regions absorb the higher costs from being repooled with Monterey County. And I think there could be some agencies with strong outside options, like some of the cities, Palo Alto, for example, could think that they're going to get a better deal if they just negotiate directly with Kaiser or Sutter or self-fund and withdraw from CalPERS health coverage altogether. So is this regional restructuring evaluated on the assumption that the current membership holds, or have we modeled a scenario where a large low-cost agency withdraws, and then what happens that remaining risk pool? Does it shrink the cost alignment gains that we're counting on and make it even worse for those members then?
Yeah, so that's a good question, and that is a very reasonable concern. The short answer to it, and it's one of the things that I think we will be coming back to again and again as we massage these maps and try to reach a final outcome, is that under the existing scenario, we're seeing that right now. But what we're seeing is Southern California employers leaving CalPERS because our premiums are overpriced relative to the market, and so they can get a better deal somewhere else. If it shifts, if we were to make the regional adjustments and say, for the state of, or for the purpose of this conversation, perfect alignment, we would see some of those pressures go other places. However, when you have alignment of price, the competitors in those Northern California counties, in the Bay Area and in Monterey, are not able to put a competitive product out on the table that is going to be significantly lower than the CalPERS product, because the cost of providing the health insurance is much higher in those counties. So what we would be doing essentially in those higher cost counties is competing based on our ability to put out a high quality competitive product rather than on an artificial subsidy that is coming from the fact that we're overpricing in Southern California. So it is, all of this involves a certain amount of disruption. That is not something that we can get away from. We think that right-sizing these ultimately will be less disruptive, and keeping markets tethered as close as possible to the actual costs is going to make us most competitive over time.
Okay, and then just process-wise, and I suspect the answer is yes, more complicated, but so if an agency were to come to us and say, hey, I'm going to withdraw because the costs, I can't handle these increases, especially looking at, I mean, on scenario C, where are those 700 members with the over 15% premium increase?
That is a Justin question.
I can pull that up for you.
So my question ends up being like, when an agency will come to us and say, hey, we think we can get lower costs somewhere else, we're going to withdraw, is that conversation then going to happen? Is there a process for that conversation to happen very intentionally, or even in the conversations rolling this out to agencies preemptively?
Yeah, I mean, before he gets into the where these folks are question, absolutely is the short answer. We have a whole team that works with employers to try to retain them and to recruit them. So we go in and we market in these across the state to try to recruit members to the CalPERS health program, and it is a combination of cost, which is their number one concern, and the benefit, which they seek. Their members know that it's a high quality benefit, that we put a good product on the table, and that is compelling for them. So we engage. I hear from Yesenia months and sometimes years before an agency is thinking about leaving CalPERS, and we have a whole team that actively works with them to address their concerns and to try to do what we can to retain them.
Thank you.
And I just want to add on the termination piece. Whenever there is
like Don mentioned, whenever there is an agency that is looking to terminate, we do a lot of active retention efforts to hear the concern and to work through that. But if ultimately there is an agency that wants to terminate, there is a window period that agencies can elect to terminate, and it's 60 days from the point of the board approving the rates. So the board approved the rates today, so it starts 60 days from today is the window period for an agency to elect to terminate their contract. Each year, that window period starts, and it's for effective date of 1/1 of the new year. So that would be the term period. They can't terminate mid-year, right?
And to your question about the 700 members, we estimate that approximately 10% of Marin County would be affected and most of Santa Barbara.
Okay, thank you.
You're welcome.
If I can add just one other thing, you know, and apologies for this, but I'm going to say it anyway. You know, this is a frustrating map to see. All of these maps are frustrating. I've said this a million times, but when I got to CalPERS and saw the distribution of costs across the state, it was the thing that I figured that I could go and retire if we made a big dent in. We shouldn't be in a position where we're seeing these big fluctuations. The best option here is to address the high costs in some of these high cost areas, which is why you hear our team talking about places like, because we're in Monterey, I'll say Monterey all the time. And the intent here is not to cement this and then not revisit it. If we are able to make progress in some of these places, like Monterey and some of the other high-cost Central Coast, Bay Area, et cetera, we would update the map because we would have to, right? This whole exercise compels us to do that. So as we make improvements in addressing the high-cost places, we're in a position to modify the regions accordingly.
Excellent. I believe Mr. Palkey's next, and then Gail is after.
Yeah, thank you for the presentation. I know we're talking about regions, but I do know that one of the hot topics at schools is providing healthcare to part-timers as well. Whether they choose to utilize it or not is another story, but and a local issue. Are there regulations that prevent us from offering that option or that availability to like part-time workers and things like that when it comes to schools? Or I don't know how it works in private or public agencies.
So in order to offer or to be eligible for health, you have to be in a position that is part-time, permanent or part-time, which is 20 hours a week or more, right? But for our contracting agencies, there is a section in PEMCA that allows them to contract to allow their less than part-time individuals benefits, to offer that for them. They just need to elect that resolution if they want to offer that benefit for their less than part-time folks. That's something that they can elect to offer. They enter into a contract with that. They need to fill out a resolution approved by their governing board, and then those less than part-time individuals would become eligible for health benefits through us.
Thank you.
Yep.
Okay. Gail? Good morning. Thank you for your presentation. I have 3 questions, actually. The first one is, so what made you decide to do the quantitative survey, which focuses on how much and, of course, uses the measurable statistics, versus the qualitative survey, which explores the why and the how in a more detailed analysis, more descriptive, I should say. And then my second question is, you specified that you sent out 4,862 surveys and you received 356 responses. Is that correct? Okay, which is 7.3% response rate. Have you discussed with your team on how to increase the response rate? Thirdly, you emphasized that Kaiser was excluded because their data was different. In what capacity was Kaiser's data different?
So, I'll start with these, and we can. So on the quantitative qualitative question, it's a quantitative question because what we're trying to do here, it is in part a quantitative question,
right?
Because in part what we're trying to do here is match cost with cost, which is a question of hard numbers. We did the employer survey, asked qualitative questions. What do you care about, right? And they told us things that are qualitative in nature. We care about price. We care about administrative simplicity or complexity, et cetera. So that was the motivation behind the second component, which is much more qualitative, which is the survey, to ask them their opinion. So it's a little bit of a mix.
Right. Okay.
Yeah.
Good.
On the response rate, so the response rate from people was 7.3%, but we sent the survey out to all of our contacts, and we have multiple contacts at lots of agencies. So the response rate by agency is 20%, which is does not sound like a 10, as in really great, but for a survey is pretty good. It is higher than typical response rates in lots of other surveys. When you think about political surveys and things like that, those numbers are way, way lower. So this is, it is not 100%. We will not get to 100%, but 20% is more representative. We've also found that people who have deep thoughts about these things, or not say deep thoughts, let me say strong thoughts and feelings about these things, tend to respond. So we are hearing from people who care at a disproportionate clip. Sir, third question was about Kaiser.
Yeah.
So Kaiser is just, and I'm loath to say Kaiser is a different beast and we should treat them differently, but Kaiser is a different beast in this instance because Kaiser is an entirely integrated system and its prices are much more statewide. They basically are Northern California and Southern California prices for the most part. Their costs will fluctuate a little bit by labor costs within an area, but you're not going to see price variation of 4 times when you compare one Kaiser hospital to another Kaiser hospital. It's standard, so it doesn't make sense to factor them into their regional variation.
Thank you.
Yeah.
Great, thank you. Mr. Rublikova, did you have another question?
Yes.
Thank you. It's on, but you got to lean close.
Thank you. That's going to follow up on that.
I don't think it's on. Is his mic on? It's on. Sometimes they're still not working.
Grab the next one.
Go ahead and talk.
Yeah, there you go.
That one's working.
Sorry, Don. Let me turn this one down. Yes, my question concerns risk pool. I know nobody's in favor of premium increases, but in high cost regions, the CalPERS plan could still be more competitive than what's available to the employer. And I think we have instances with a lot of people who are joining are actually worse utilization, actually deteriorate our risk pool, and we have to absorb them. We have no option. Is that correct?
That's correct. We don't do any underwriting here.
Right.
We welcome everybody.
So I think we should keep that in mind as we have this discussion, because likewise, I think, so we have to see why people join and why people drop. We of course don't want people to drop, because that we could use the healthy lives. But I think we do see big significant employers coming into the system, like the County of Riverside a couple of years ago, even though they're in a lower price region, because we do have high quality plan, more comprehensive benefits than they can provide through their own agency or what have you. So I think While disruption is an ugly thing, cost, healthcare, healthcare is going at I think somebody mentioned it earlier in another session. Health inflation is maybe 3 times regular inflation, so it's not a good thing. But until we come with a comprehensive system in the state or nationwide, whatever, we have to try to figure out how do we give the best healthcare accessible and affordable to its average. So I appreciate the work that was done. There's going to be hard decisions for this board, but I would also want to balance that we do want to attract more employers, more agencies, and I'm glad we have some staff that handle that, and I know there's some successes, but we do need to work on understanding the impact of the risk pool also. Thank you very much. Yes, I guess it was more of a comment than a question, but I wanted to do that. Thank you for allowing me to do that.
Okay, awesome. David, go ahead. Yours isn't on either. Can you make sure?
There we go.
There we go.
Just got to get up there for that proximity effect. Yeah, I really appreciate the presentations. I appreciate the discussions. I think all kind of my substantive questions have pretty much been asked and answered. I do kind of appreciate scenario C as a potential recommendation. But as kind of a non-substantive thing, maybe it's more semantics or window dressing, but I really don't think I have a real grasp of the impact of, say, the issue of, whether these things are contiguous. So, for example, in this example, if we went and did, 1A and 1B or an 8, with or without any kind of differential rating that would change Santa Barbara or anything a little bit or not, is that something that would have any value, or would that pose any kind of significant administrative? Because it seems like it would be perhaps cause less concern, even though having one small region just to address Santa Barbara, rather than having people feel like, why are we in with Eureka?
Yeah. Justin, do you want to take this one? Or?
I could speak to that. We looked at the average volume of regions, like the average number of regions that public agencies would have in contiguous counties for scenario A. And on average, there would be about 3.5 regions in and around counties, whereas compared to scenario C, it's about 2.5. So it's a pretty significant reduction as far as administrative complexity goes.
The other thing is that we really didn't, so, the first map you saw was of a ton of different regions. And the third map you see is of 7 different regions. We don't get that much more bang for our buck going over 7, and we do create more administrative complexity. So there's a little bit of a difference between the price alignment in the map, the first map A, when you compare it to C, but there isn't much of a pickup when you add, an 8th and a 9th and a 10th region. So we were making the sort of assumption that the net gain in administrative simplicity that you get for having fewer regions is probably a pretty good trade-off. But we'll hear from employers and potentially from members about some of these things in the coming month or two.
Yeah. So I guess, if we would just leave C as it is and make Santa Barbara 1A or make it 8, would that be substantively any difference if we weren't really or would just have any benefit just for appearance and understanding of our members?
We can look at it. The short answer is probably not, but that was my recollection. But we're happy to look at it.
Okay, because I understand. I mean, the permutations of this are endless, the possibilities. So I appreciate staff getting through all this and bringing us something that's concise and so understandable.
So real quick, as I'm looking at the map again, it appears that Yolo County is not in our county of number 2. It's in appears to look like just the other side of the Bay Area, right? Number 3, yeah. Are those costs closer? Because I do remember when we were separated from Yolo before getting members' complaints because they would normally drive in to go to UC Davis or something. So that might be a miss. I don't know. If you could tell me how that fit in there, that would be nice. If you can't,
Sure.
that's fine. I
No,
know
for
this
sure.
is
It's a delicate balance of number of members in a region in addition to the cost of the region. On a cost basis, it's close. I'd have to look at the member counts to see how it affects the overall averages. But we could see about any kind of county shifts as well.
Have you guys thought about zip codes? I know that gets really, really bad, but I'm thinking the zip codes closest to Sacramento County might be your way, because I think maybe the rest of them go the other way, but I don't know.
Yeah, I think that 90% of the people in West Sacramento work in Sacramento.
Right, that's what I was thinking.
Yeah, Yolo and Sacramento are that's a hot spot that we've spent a chunk of time looking at. It's tricky because of the way employers are. One of the things that it's occurring to me that would probably be helpful is we can, when we come back to you in September, we can also include information about the relative differences in cost from region to region.
Okay.
I think that would be an important data point as you continue to consider this. We're happy to do that and look at the practical difference between those two regions in particular.
That might be helpful, because if our members are like, well, I want to go to UC Davis, but it's cheaper for them to be in this region.
Yeah.
So,
Well,
yeah.
and remember that we have members who use their home zip code, and we have members who
use their work zip code. Yeah.
Yes.
And you can use either, right?
Correct.
So if they work downtown in
Yep.
Sacramento,
They would have a choice.
Okay.
Yeah.
All right.
Yeah.
Alrighty, so thank you very much.
Oh,
Do I have some?
one-
Oh, David, you're still
Just
going.
a little, just to piggyback on President Taylor's comment about YOLO and UC Davis and how many folks up in the Sacramento area utilize them. And I really don't understand how it all works with their integrative care models, but sometimes you'll routinely have appointments at UCD Med Center here in Sacramento, and all of a sudden you'll get an appointment, say, an endocrinologist or someone over there, or vice versa. Someone who lives in Davis will find that if they don't want to wait another, 3 months or something, they'll get them in over here. And so there's a lot of,
Roseville.
15, 20-mile running back and forth difference, especially for someone like in West Sac, where you can almost split the difference.
Yeah.
So, not that it impacts this, but just in practical terms for our members.
Just a whole lot to think about. I want to tell you all I appreciate the hard work that went into this. I know a lot went into this, and this is one of the hardest things we do, and we've done it, I think, this will be the 3rd time I think we've done it since I've been here. Yuck. But I do appreciate it, and I look forward to seeing additional information that folks have asked for. So again, thank you very much. Great presentation.
Thank you.
Before we move on, I do have a comment from RPEA and JJ.
Is this on? Yeah.
Yep.
JJ Jelensik, RPEA. I've been around long enough that I remember when we had no regions. And I will also tell you that most of our members are in Medicare, and so they're not directly impacted by this, although we do have a number of members in the basic plan. The concept that the premiums should reflect the cost should not be particularly novel. The issue that some people are going to see an increase in the premiums, in part because they're losing the cross subsidy of being grouped with lower cost areas. I will tell you that as you do your town hall meetings, if my county is more expensive than the next county, I'm going to urge you to put me in the cheaper county. Doesn't make much difference whether the rationale of it is, but that's cheaper and that's where I should be. I remember one year, Yolo County and said, we're in the Bay Area and we should be in Sacramento area. And the board agreed to it. One of the things that happened is about 6,000 people in Yolo County saved $1.80 off their premium. This is my memory, may have been a little higher, but 55,000 people in the Bay Area all picked up an extra 67 cents to subsidize the move of Yolo County. So I will tell you that's what's coming, and I will also warn you, board members, that you're going to hear pitches, but they're cheaper and they're just across the street from me. And I urge you to stand tough. The premiums ought to reflect the actual costs. Thank you.
What do you think? Okay, great. So thank you again, guys. And we have coming up now is AI and primary care with Don Moulds and Dr. Logan, Dr. Julia Logan, and Eric Schneider from Dr. Eric Schneider from Harvard School of Public Health. If we could all come up front.
We okay going? Good to go? All right. Good morning. Today I have the pleasure of introducing my friend and former colleague, Dr. Eric Schneider. Eric is adjunct professor in the Department of Health Policy and Management at the Harvard T.H. Chang School of Public Health. He is an internationally recognized expert on healthcare quality. His previous roles include Executive Vice President at the National Committee for Quality Assurance, or NCQA, Senior Vice President at the Commonwealth Fund, and Senior Scientist at RAND, where he held the RAND Distinguished Chair in Healthcare Quality. He was full-time faculty at Harvard School of Public Health and was Editor-in-Chief of the International Journal for Quality in Healthcare. He practiced and taught primary care internal medicine at Brigham and Women's Hospital and Harvard Medical School. Eric is a graduate of Columbia University, the University of California at Berkeley, and UCSF, where he went to medical school and was a resident. In the years I worked at the Commonwealth Fund, Eric taught me most of what I know about healthcare measurement and quality. He's been a friend to CalPERS, helping us think through important issues like how to measure quality in behavioral health services. And since returning to Harvard, Eric has been busy going to a lot of Red Sox games, being an enthusiastic grandfather, and thinking and writing and teaching about AI in healthcare. It's the last topic, not the Red Sox, specifically AI in primary care that he's going to talk with us about today. So Eric, thank you for making the trip out here. I'll turn it over to you and Dr. Logan.
Wonderful. Thank you very much for that incredibly kind invitation and introduction. It's really a pleasure to join you in this beautiful place. I always appreciate the opportunity to share my thoughts about primary care in California, because this is where I actually trained and started my love of primary care that led to a career of over 3 decades practicing, teaching, and studying the topic. This is a pretty fraught time for primary care. I think everyone is aware of that. The shortages of primary care professionals and the impending federal Medicaid cuts are going to make this a challenging time going forward. But at the same time, we're in the midst of an AI revolution, and AI is now quickly infiltrating primary care and has a potential, in my view, to transform primary care more than any other technology I've seen during my career. And it can either benefit or not benefit the people who receive primary care. And so that's the topic of my talk today. I built this, what I hope will be a brief overview around 2 words, promise and peril. And my goal is not to sell you the virtues of primary care or to bash, or sorry, of AI, or to bash AI, but actually to just offer a framing so that people can ask the questions that will matter going forward about how to implement AI. So let me start with primary care. What is primary care? Maybe that's an obvious question to ask, but I bet if we asked around the room, people would have different answers to that question. Barbara Starfield, who is probably our preeminent primary care researcher, made the point that although the U.S. pays for services, what primary care is about is really 5 functions, and those there are primary care functions and specialty functions in any healthcare system, and her international research sort of shows that primary care, success at the primary care functions is actually what determines whether a healthcare system is accessible, affordable, and effective. And I start here mainly because if we ask the question whether AI tools are helping or hindering primary care, we should just be clear about what it's trying to achieve and what those functions are. An AI tool that speeds up visits but undermines care function like coordination or continuity won't be an improvement. So what are those 5 C's? The primary care functions are listed here. First, contact access. It's the front door of the healthcare system. Longitudinal continuity, so actually knowing the person over time. Providers knowing the people, teams knowing each other. Those relationships are more, in some ways, more important than the one-off visits. Comprehensiveness, caring for the whole person, not just one organ. That actually is our specialty in primary care, is the ability to see across all of a person's experience and systems and solve problems that specialists sometimes can't see because there are too many systems involved. Coordination, pulling together the fragmented nature of care in the U.S. And creating that sort of portfolio view of a person. And then finally, person-centeredness, care that's organized around an individual and their particular needs. So you can actually think of these 5 C's as a sort of scorecard for keeping track of whether AI is delivering on its promise. You can ask whether an AI tool, when it's implemented, promotes better longitudinal continuity or whether it hinders it. And if, say, you get first contact access, does that gain come at the expense of undermining continuity or personal relationship or coordination? So that's one rubric I think that might be useful going forward. The other thing to talk about are the 2 flavors of AI for primary care. This is AI in general, actually. It's not just unique to primary care. But the breadth of the term is somewhat challenging. Asking how AI will have an impact on healthcare is a bit like asking how aviation will have an impact on commerce in the U.S. You can think about aviation includes commercial jetliners, helicopters, military fighter planes, drones. So the use case actually matters when you sort of try to talk about this. And for healthcare in particular, I think there are 2 flavors that are worth having in mind as we think about the future. The first is predictive AI or machine learning. And this is actually a pretty mature field. Machine learning's been around for actually probably since the 1940s when Alan Turing started speculating about it. And it's basically where AI finds patterns in structured data and basically outputs a score or a category This is reading medical images, producing risk scores, predicting readmissions. It's pretty validated at this point and useful in a variety of areas. The main questions to ask about predictive and machine learning tools is whether they are accurate and unbiased for the particular population that they're being applied to. The second flavor of AI for primary care is the generative AI. These are the large language models. And this is I think the crux of a lot of anxiety. Generative AI creates new content by absorbing old content or prompts. And it can generate text, images, audio, ambient note-taking, documentation, chatbots, drafting, summarization. Those are all generative functions. And it is much newer, evolving much more quickly, and much harder to validate in general. So, and I'll talk about this, the main risk is that it can be fluent and confidently wrong at times. And that's a serious risk in healthcare in particular. So finally, just to set this up, I'm really going to talk about the challenges of emerging AI, which fundamentally boil down to the current capabilities and promises versus the real world benefit. And this is where the promise and the peril come into play. On the left, the promise, in controlled settings, in laboratory settings, AI often bests or beats clinicians at their own game. AI models can actually do better at diagnostic reasoning, accuracy. They can extend specialist insights onto your phone. As a primary care doc, I can look up what the specialist guidelines recommend for a particular type of care. Now, I used to be able to do that anyway. I could do that by retrieving the guideline, reading the guideline. But now I can just ask the question and get a pretty complex and comprehensive answer to it. And in randomized trials, AI basically can beat clinicians about 77% of the time on basic tasks. On the right side are the perils. And it's not the opposite of the promises. These are really the footnotes or the cautionary notes about the technology. Accuracy in controlled settings has not yet been extended into real-world clinic settings. The benefit of models being, and the risks of them being confidently wrong or hallucinating are still being studied and understood. And then bias in the data can widen and not narrow health disparities, which is among the perils. And then we have issues some of which came up yesterday about over-reliance, cognitive surrender, eroding clinical skills that can come up. And those benefits are really only realized if there's a good fit between the AI tools and the workflow that exists today. So let me walk through 4 promises. The first is the better chronic disease management promise. The reason this has been studied as well as it has is because most of our spending occurs for chronic diseases, and they're relatively common. And we know that for 2 conditions, at least diabetes and cardiovascular care, AI can improve patient evaluation and early detection of disease. And it is particularly helpful to clinicians when they're trying to optimize treatment across multiple conditions. AI is good at handling that complexity and creating summary. Continuous monitoring and risk prediction. AI does really well at that. Coaching and adherence support for diabetes and hypertension. AI models are really good at communicating in the preferred language of a patient or the preferred educational level or reading level, or audio for that matter. And they're pretty good at summarizing and managing complexity for patients with several conditions at once. And I put some data points from a few studies. These are different studies, so don't take these as one sort of overarching result. But basically, overall, you can see for these 4 different tasks, AI does really better than usual care. The second promise is around relieving the documentation burden. And this may be more apparent to most people than anything else at this point, because this is just burgeoning. There's a ton of dollars gone into this, investments, and these tools are out in practice. And if you talk to any primary care doctor who's using these tools, they will just start gushing about how effective they are and how helpful they are. The promise of the documentation reduction is the ambient scribe, which is listening and documenting so that the doctors can actually, clinicians can pay attention to the patient. And the reduction in paperwork that comes with that is really dramatic for primary care physicians. And I actually just retrieved, there was a Canadian study they gave 10,000 licenses for ambient scribes to 12,000 clinicians in Canada. And there are some real hard numbers to support these points that are on this slide. On average, clinicians saved an hour during the work week, during their work time, and another hour or more on weekends and nights. The time was reinvested in getting other administrative tasks done. They were able to reduce patient wait times in many clinics. And 3/4 of the patients, the clinicians who were surveyed said that they basically could review these notes quickly and correct any inaccuracies. And that's sort of a key point. There was a need for human review for these generative AI tools. The important caveat to these benefits, less time on paperwork, lower risk of burnout, more retention of clinicians, and faster access and coordination. The benefits actually only occur if the time that's saved is redeployed effectively. And so some people have said, well, now we can actually, each clinician can see more patients per hour. And if that's the case, it's going to be sort of higher billing, higher spending, and more the same burnout rates that we've observed before. So that's not a technology default. That's actually a workflow deployment organizational management challenge as to how to redeploy this new saved time. But I can tell you as a primary care doctor, talking to other primary care doctors, they're over the moon about this technology. The third promise is expanding access to care. And here the story, or at least the best published literature, comes from low resource or resource constrained settings, many of them in other countries where underserved populations are receiving care. And this might actually be especially relevant to the underserved areas of California, which I understand there are 661 health professions shortage areas in California. What AI is delivering here are better decisions in high volume clinics, catching disease earlier at the point of care, which would otherwise go undetected because there are few contacts between patients and doctors, smarter screening, less waste, and reaching rural and non-English speaking patients, especially in other countries. Interestingly, in these settings, the biggest access gains show up where human expertise is in short supply. So in other words, the test in many of these studies isn't how does AI perform compared to usual care, it's how does AI perform compared to no care. And so I think it's worth bearing that in mind as you're looking at this literature. And the other caveat, which will come up again, is that these gains only reach the underserved populations if the tools are designed and deployed with the needs of those populations in mind. So one-size-fits-all generic AI tools to solve the problem of underserved areas is not a good approach. The fourth promise is behavioral health. And we've already heard some great discussion today about behavioral health. And here it is really two sides of a coin. This is scalable behavioral health screening and support but also where there's the most danger right now in terms of the current tools. On the opportunity side, automating screening tools has been important because it's enabling the detection of disease in primary care that might not otherwise happen. And that sensitivity can be up to 96% with these tools compared to usual care. Structured chatbots have also been shown in some small randomized trials to reduce symptoms more effectively for depression and anxiety than usual care. And those are dramatic numbers, 34% versus 20% sort of improvement in symptoms compared to usual care. This promise comes, as you'll see, with the bluntest safety warnings. In fact, you probably have even read about these in the lay press, that people can bond with these chatbots. They can validate harmful thinking. They can worsen crises in vulnerable users. So people with mental health conditions who are vulnerable, this is a double-edged sword. It can be helpful or it can be extremely harmful. In a meta-analysis, only 3 of the 22 chatbot trials that were done in this area were actually tracking adverse events. So there isn't a, when you see a report that says, well, there were no safety events with our chatbot, they might not have even tracked the safety events. So the absence of safety problems doesn't mean there was no harm. And then I think the consensus at this point is that these chatbots and other behavioral health tools are best used as an adjunct to human interactive care, not as standalone, although they're frequently used in that context. All right, let me turn to the perils. And this is probably my favorite peril. Confident but sometimes wrong. If you've ever even interacted with a generative large language model, you've seen this in action. It'll give you some crazy answer, and when you ask it, are you sure? It'll say, yes, I'm absolutely sure, and then you point out that it's wrong. It says, oh, I guess you're right, I'm wrong. And those are hallucinations. And I think the challenge here is that they're incredibly difficult to detect and prevent. So safety testing is still in its infancy in terms of understanding how to intercept these hallucinations, because they can arise just sort of out of the blue. I mean, these are probability machines, so it's not actually surprising that this would happen, right? There's going to be some probability of these getting through. And most of the technologists, I think, are using systems that check the veracity of outputs from models. So it's models checking other models. Go down that rabbit hole. So anyway, the challenges here in healthcare specifically is that overconfidence and rigidity is not helpful in healthcare, because context really matters for what the right course of action is. And the models have no judgment whatsoever, and they have no understanding of context. They're not designed to do that. They can trigger unnecessary testing and follow-up, so that can add costs unnecessarily. And notably, to my knowledge at this point, no generative AI large language model has been FDA approved for independent clinical decision making, although there have been, Utah was looking at prescribing, allowing chatbots to refill or LLM tools to refill prescriptions. But I think the risks are real. There's a study, this is not peer reviewed, so I say this with caution. In fact, it's already been revised a bit, but the fundamental findings are probably real. It's the so-called no harm benchmark, and they've tested, it says 31, but I think it's 28 AI models on 100 real primary care to specialist consultation cases. And they found that up to 22% of those, and it ranged from 7% to 22% depending on the model, were actually making recommendations that could cause severe patient harm. Now that's pretty striking. About 70 to 80% of those errors were actually errors of omission. So the model didn't recognize a fact or a problem in the case that would lead to a recommendation by a human clinician. And so these omission errors are really hard to pick up. And even humans, especially if they're over-reliant on the technology, may not appreciate the need for a different recommendation than what the machine is presenting. The thing that's interesting about this study compared to the others that have been peer review published is most of the studies take like published clinical vignettes that have been well worked out and the data are clear and all the facts are included, and they compare that to AI versus a human, a doctor or expert or specialist. In this case, they actually took real digital data from health data records of a health system, which has all the messiness of real-world healthcare data that clinicians spend a lot of their time plowing through to try to sort of ferret out what's real and what's not. And so this study, to me, and it'll be interesting to see how this evolves, it's an ongoing project, tells us what this would look like in real-world implementation. And I think that identifies a peril we have to be confident about. The next peril is the potential for AI tools to undermine equity goals. And the key here is the algorithmic bias challenge, which I think is fairly well known. It's been first published about 10 years ago almost now. But the idea is that the AI is only good as the data that it's trained on, and healthcare data are only as good as the healthcare data that were reported, and they reflect whatever practice was over the last 20 years. And those training data are incomplete, and they're incomplete in biased ways. So there are populations who didn't receive care, and the AI model doesn't know that they didn't receive care, it just observes that their care wasn't delivered and can build in that bias. And generative models trained on historical data, where there are gaps, those gaps will just be magnified, amplified, and carried forward. So incomplete or poorly trained models can further entrench disparities. Beyond the algorithmic bias challenge, though, there are other challenges around access. Do people trust AI? That's a moving target right now in terms of the public level of trust. The dehumanization that people sometimes experience with new technologies in particular. Effects on self-care agency, the feeling that I'm responding to a machine, I'm not taking care of myself. And then other system effects are all ways that AI can affect equity. Beyond so the two hard truths, I think, emerge in trying to address these equity issues. One is that there's a trade-off between accuracy, model accuracy, and model fairness that designers have to be very conscious of. Technical fixes to address problems for one group can actually introduce problems for another group, and so it takes a fair amount of human judgment to manage that trade-off. And then there's the well-known digital divide. People who have access to these technologies versus people and practitioners who won't. So I think a key practice or a key insight, I guess, out of all of this for practical purposes is that it's important to ask, how was a model trained? What populations was it trained on? Did it include relevant populations? And is it being now applied to a different population or a population like the population it was trained on? Not an easy task, but certainly an important one. We talked, this came up quite a lot yesterday, whoops, I went too far, around the cognitive surrender, I think was the term that stuck with me. And these are, in healthcare, these are sort of slow-moving and slowly developing risks around over-reliance on AI. So clinicians trained with AI, we don't know, or we're only starting to know how effective they are at questioning the AI outputs. They may not even learn the sort of basic clinical reasoning because they're sort of delegating it to the machine. So there's de-skilling of skills that you once had that you now don't need to exercise anymore. It's like navigating with a paper map. Who's done that in the last 5 years? Never skilling, like just never learn. Being given the wrong skills because the AI does the thing differently. And then automation bias, which automation bias is this sort of tendency to accept whatever the machine reports out as the truth. And then I think there actually have been some good studies of the patient relationship and concerns about AI-mediated visit, whether there is a loss of empathy, human connection, and trust, and a fear that clinicians will be distracted by the AI, although that may be oversold in the sense that clinicians now used to be distracted by their computer screens and inputting data. Now they're distracted. If they're distracted by AI, that's a different problem, I guess. And then I think this is another one. I just heard this morning that the federal government is now conditioning aid to African countries on access to their health data. Unbelievable, actually, that digital health data of other countries is now part of a deal and may go to private companies for receiving aid for health. This is going to be an ongoing challenge and issue around the privacy and security of data used to train the models, taken in by the models in order to produce the results. Those large volumes of sensitive patient data are creating new exposure points for the privacy and security of individuals. There's a workload paradox. This is the classic alert fatigue problem where the machine starts generating suggestions, recommendations, reminders, and unnecessary testing prompts that just actually eat up more time than what they were meant to save. And then there are liability issues that I don't have time to go into here, but the notion that the developer, the system, and the clinician all have sort of joint liability, at least on paper. In regulation, I think it's the clinician who's holding the bag at the end of this, but if something goes wrong and there's harm, who really is responsible and liable? So what I've tried to sell you is that integration, the algorithms themselves are a tool like any other tool. It's how they're applied in practice that's really going to matter going forward. There was a really good study of this, of a lovely UK-based algorithm to detect heart failure and heart rhythm problems. 205 UK primary care practices. The algorithm was great, no improvement in detection whatsoever, and it was because the device didn't fit the way workflow happened in clinics and nobody was really using it. So you can spend a lot of money on a technology, and if it's sitting on the shelf gathering dust, there's no real benefit. And that really drives home the point that it's the workflow, the fit with clinicians, clinician training, transparency, and trust, and co-designing with the users that really is going to make the difference for AI in primary care and healthcare and probably in the general economy. I'm not going to spend time on this. I was going to have a whole other talk on how people are using AI outside of traditional healthcare, but maybe that's a topic we could come back to another time because Spain versus France is soon underway. And then there are some well-developed frameworks and guardrails and works in progress around how to monitor and oversee AI tools. And again, you have these slides, so I think I'll leave this for discussion. So the final takeaways are the promise is real, but a lot of uncertainty. AI can outperform clinicians in a controlled and laboratory settings, but whether it can do so in real-world settings is still an unclear answer. The risks are real, and I've outlined several of them here. And effectively integrating AI into the AI-human interaction this is a bit like, we all had to learn how to drive cars and not run into each other. We're going to have to learn how to drive AI and not be driven crazy by it. And then the impact on equity really depends on deliberate design choices. And then finally, governance is a work in progress. And federal and state regulation, or maybe that's your department, Don, for another day. Anyway, thank you for your attention, and I'm happy to try to discuss in any way that would be helpful.
All right. Well, we really appreciate the presentation, and I had lots of questions as I was going through, so I've probably forgotten them by now. But, and I think they end up getting answered later. So it's already in my doctor's office, right? My primary care physician always asks permission. if they can have it basically recorded so the AI can take the notes.
Yeah.
So she doesn't look at that. She doesn't get distracted by that, but they still have to get on the computer and do things. So while we're talking, like order tests and stuff like that. So it is being used, at least in my experience. I thought it was interesting, the opportunities and the, on page, hold on, 170 of 547, hold on, what's the page of this? Oh, 9, there we go. The opportunities and the serious caution, and I'm glad you mentioned that because, yeah, there's a couple of really serious issues that have been in the news where somebody has gotten too attached and, yeah. Committed suicide, yeah. Was talked into committing suicide by the chatbot. So that's where I was, when you said behavioral health, I was like, ooh. But yeah, that's an interesting thought. I don't know if, is that in actual work, is that actually being used right now or not yet?
Yeah, so chatbots, it's mostly pilots and demonstration projects at this point, unless someone knows otherwise. I mean, actually, by the time I finished this talk, it was already out of date because this is such a fast-moving field.
Okay.
But no, generally, it's the independent use of chatbots. It's people just going on to whatever ChatGPT or other equivalent,
and then,
which is where I think most of the risk sits. But there are practices that are prescribing chatbots or validated I mean, I think this is actually an interesting opportunity to say there are validated chatbots that have the safety features that are needed in order to use them effectively in practice. I don't know if anyone else has observed that. But the notion would be like FDA prescribing. You don't just take any medication you want to, although you can. There's actually a prescriber who's monitoring for safety issues.
So that's where I'm also a little worried. Why FDA approved? First of all, obviously we're not getting any federal regulation on AI right now, right? So the state has to regulate, and then I think if we're working in healthcare ourselves, right, we should be convening folks to do some sort of values work and some guardrails, right? So that we, especially in healthcare where there's a lot of information that could get out. And go ahead, Don. It looks like you want to say something.
I was just going to say that we've been doing that for a while now, but we're starting to ramp up our efforts as it becomes more part of the healthcare experience. So we've been starting to compare notes informally, and I think soon more formally with our partners at Cover California and with DHCS to think through a number of these issues and really answer some of these questions about when we need to weigh in and when we don't, and what our contract should include or don't need to include, and so forth. And it is, to Eric's point, challenging in an environment where the new normal changes every day. But that is one of the work streams that we've really picked up and we are doubling down on in the coming year.
And I don't see, large language models can't do a whole lot in terms of like being the physician or anything. I know that there's a possibility that actual generative AI may come around sooner than later, but I can't imagine that we would be dealing with AI right now as a patient, hopefully, other than in a phone tree.
So to address the primary care shortage in Massachusetts, Mass General Brigham actually introduced a chatbot front end for their primary care patients.
How's that going over?
And actually I was trying to get an update on that because it was just introduced at the beginning of the year, and the initial...
We're 6 months in.
We're 6 months in. The initial reports were anecdotal. People who couldn't get access to a primary care doctor consulted the tool, were able to get some advice for simple problems, whether it's ready to do more than just be a front door and a sort of access point. Now it's also monitored, and it's got a built-in triage that sort of sends you to a human being
if
it
necessary.
detects a problem. Yeah.
Okay.
But we're moving in that direction in ways that are surprising.
But it's still large language model because we don't have generative AI yet.
So
It's probably some combination of predictive and generative AI. That's
Yeah.
the other thing. The distinction I made is sort of a technology distinction that probably will get blurred over time.
Yeah, because they're not quite learning, they're predicting. That's
Yeah.
not the same thing. They're using a whole bunch of information to predict. So
Yeah. So we'll have to see. I mean, these things are happening in the real world, and I think tracking these experiences is important.
Well, again, I really appreciate the presentation, and it's very interesting, and I'm sure we could talk about it for hours. I have three people, so I'm going to start. I don't know who was first, but I think Kevin was first, Gail, and then David. Oh, I'm sorry, and Yvonne.
Thank you very much. First off, let me just say how impressed I am with Harvard's impeccable cleanliness of their chalkboards. It actually made me think it's like if a school or a company puts that much effort into something as small as chalkboards, who knows what else they can do on a much bigger scale. No, I thoroughly like this. I've seen a lot of current primary care providers get frustrated with the new technology, which then they end up becoming a specialist, and sort of you see a lot of the flip-flop between primary care physicians lately because of whatever they're not wanting to deal with the technology, things of that sort. So I'm concerned about obviously what is the real issues of burnout and things like that at that level for those individuals. But on a positive note, I'm also very concerned, or I like the idea of breaking down language barriers. And I was at another conference at the beginning of the year where there was eyeglasses, where you could have a prescription eyeglass and somebody could be speaking another language, and it translates right then and there. Obviously, we don't know if it understands slang or any of those sort of categories, but to be able to sit in a doctor's office with an individual that you may not be able to speak that language, and then to be able to understand via the equipment or the technology is quite fascinating. Do you see, when it comes to regulation, obviously we don't want to touch that with a 10-foot pole, but do you see, given the circumstances that we're in, do you see more businesses self-regulating to minimize risk to their product before we actually see regulation at say the state or federal level?
Yeah, I don't want to overgeneralize, but in my conversations with AI technology developers over the last year or two, they actually would appreciate some degree of regulation to build in guardrails across the industry, and they're actually trying to develop their own codes of conduct that address some of these safety-related issues, because the entire industry suffers if one bad actor is crashing planes, right? So that's there has been some motivation in the direction of self-regulation, so sort of best practices, codes of conduct for AI. How that's going to play out with government level, maybe that Don can help us figure that out. But there is some interest in that. And FDA has made really, I think, strong efforts in this area, going back to the development of a software as a medical device model. What I think is impossible for FDA to do is to come up with a regulatory regime for some technologies that are changing so rapidly as these are. But they are the kind of natural home for the monitoring and regulation of safety of these technologies, but it's just a really tough task. So I think industry does have to play a role.
Yeah, because part of me is thinking, obviously, cultural differences, things of that sort.
Yeah.
Some people are more susceptible to certain medical issues than others.
Yeah.
And if those algorithms have a bias on them, that could do some serious damage to the individuals, let alone the company that's providing that product. So.
Yeah, there's probably some role for liability and consumer protection law as well.
No, thank you.
Gail?
Thank you, Dr. Schneider. You did an excellent presentation. I have a couple of questions. First one is, how does AI address the workforce shortages in the healthcare industry? But you mentioned a few, streamlining operations, et cetera. If you can elaborate on that. And then you specified that using AI as a one-size-fits-all is not an advantageous approach to underserved communities. So I would like you to provide clarification with that analysis as well.
Sure. Yeah, so I think the benefits are the operational efficiencies gains, and so each clinician being able to do more is currently the model for thinking about this. So the idea that there is a chatbot front end that can handle maybe 60 or 70% of what's coming to a call center, that actually unloads work from nurse triage or other clinicians who can then focus on the problems. And I think that works all the way up the chain. So every person is working to the top of their license sort of model, and the technology is taking care of the more routine things. Still a lot to work out there, but I think that's the expected efficiency model. Yeah, what I meant on the one-size-fits-all is that is really about the fit between the training data and the specifications for how the training would occur. And this is a really active, interesting area, because models are training to optimize around an outcome typically. And who's defining what that outcome is unclear. So some models are maybe trained to like, well, we want to optimize to reduce utilization. That's a different outcome than we want to optimize to improve the health of the population. And so I was just recently listening, it was just a month ago, there was a webinar on this topic of, well, actually, who's deciding what we're optimizing for when we deploy these models? So there's both a training aspect. Is it trained on people like the people who are going to be the beneficiaries of the outputs? But there's also this optimization, like who decided what the model was trying to optimize toward.
Makes sense. Thank you so much.
Yeah, no, thank you.
Interesting.
It's endlessly fascinating. The more you dig in, the more complex it gets.
I'm going to just go straight down the line. Yvonne Walker, and then David.
Hi. So I was glad to hear that, they are at least acknowledging the inequities. But what is the work that they're doing? Because if you're building a system that the same people are, part of the inequities, and then they're inputting the data, it just grows exponentially.
Yeah. Yeah, I think that, and this is a tricky one, and I think what I've seen is large health systems that are using the models, for example, to do predictive algorithms around where the needs are in a community, and deliberately aiming the model at where are the greatest needs and where is the greatest level of potential for impact. And so then that could be a generic model, but you're using the inputs to guide mobile vans, for example, to communities, or put more resources into communities where there are needs.
And so how does that translate over to, and that's good, but then how does that translate over to, and having experiences, you see the doctor, you're saying, and then they, it's something different, and you got to keep going and constantly advocating, and then going to WebMD to, get, some kind of, so I mean, I don't know, I just see it as another way for certain of our communities to be left behind. Even though it's a good thing, I don't think we should do this, but I think that there should always be at the front of our minds the impact and for harm. Like, when you think, like, I think it was Serena Williams when she had her child, right?
Yeah.
She had Serena Williams, so it's not a money problem. It is not a seeing healthcare problem. It is, she is a black woman having a baby, and they don't pay attention to what you're saying and how you know your body, kind of thing. And I don't get how that translates over to AI saying, like, oh, you're a black woman, we haven't given you good care, I'm going to try to do better.
Yeah, I haven't seen that yet either, but I think that is an aspiration for the equity agenda, is to create AI models that actually do that, or to train the AI models from that perspective. So optimizing the user's experience, whoever that user is, can be a goal of this. Now, I'm not sure Meta or, you know, whoever these big hyperscalers are. I'm not sure that's in their wheelhouse, or whether they're even interested
Or
in that.
they even care.
But the potential is there to design the tools. That's one of the points I was trying to drive home, is that deliberately designing for those purposes, these tools are flexible enough to enable that.
Right, yeah, but then like in our experience, like what
That's a really important.
other times when they've done stuff like facial recognition, right? It was not geared toward, you know, black faces, and so you'd get a lot of misidentification and different things like that.
Yeah.
And so, again, good technology, but then, you know, it still causes harm to a community. So anyway, I'm appreciating that you're acknowledging and looking and seeing, but I just hope in this instance we do better than we've done in the past.
I do think another area, and I'm not sure how this would play out, but AI literacy for the general population is probably another important first step, because learning how to use the tools for your own benefit and empowering people to use them in that way can also be a powerful antidote to the corporate interests that might otherwise drive the agendas.
Thank you.
Yeah, thank you. That was an observation.
David, go ahead.
Hi, thank you, Dr. Schneider. I really enjoy this presentation, and I'm only peripherally involved in healthcare these days, but I kind of notice, I wonder what is really driving the AI in different applications and sectors. Some of them that I see anecdotally that seem to be pretty overwhelmingly positive. A couple examples for AI doesn't do pathology better than pathologists, but good pathologists with AI do better than good pathologists without AI. And that seems to be an area where I really, the stethoscopes, it's funny you mention them, because a few years ago they were kind of a novelty, and I would mostly see them with new grads, interns, residents occasionally attending would have one along as a teaching tool, and they seem to be, and now I see them everywhere, and not just with attendings and interns and physicians, but I see them with nursing staff, I see them with other professionals out there, and they seem to be something that they use as both a teaching and learning tool to supplement when they're not full-time doing cardiology type work, but they seem to be a pretty positive application. On the other hand, in the behavioral health area, they seem to some of these tools seem to have just exacerbated this push to say we can't recruit psychiatrists.
Right.
Only the rich can afford real psychotherapy with a psychiatrist. Psychiatrists will prescribe medications, and we'll just try to maximize their time with them without burning them out, and we'll push everything down by expanding the scope of practice down to specialized practitioners, specialized nurses, social workers, recovered addicts who can now really talk well with other recovering addicts, those type of things. And these AI tools, they help with scheduling, they help with groups, they know all about cognitive behavioral theory, narrative theory, dialectic therapy, and they'll give you the model. You just tell them, you know, who's in your group, and scan in some information, and they'll set up your groups, they'll give you your, and it's just, it seems to be that it's focused on throughput, particularly with these private contractors that are picking up all this overflow that, and so where do you see the move toward this being driven by in the various applications you're seeing it has promise in?
Yeah, I think we're in a very formative period with this. I don't know if people are familiar with the Gartner hype cycle. If you go online, you can look that up, and we're probably at the peak of inflated expectations. We think that AI is going to solve all these problems that it really isn't designed to solve, and then things come back to earth, and we realize, well, it can't really replace psychiatrists. We actually do need psychiatrists. Another interesting observation I saw was the AI could outperform prediction. I can't remember now what it was about the likelihood of a cardiac event. And the technologists who had developed the AI said, yeah, it outperforms, but only by a few percentage points over a 7-item predictive algorithm that you can write on a piece of paper. Was it really worth the additional cost? Because these models are expensive to run. So the question was, are we over-designing for things that can be solved with simpler solutions? And I think there's a growing recognition that the marginal benefit has to really be pretty large in order to justify an AI investment.
Yeah.
Right now, we're in a sort of AI wonder world where investors are throwing money at AI.
And I'm curious, again, it's a long time since I've really looked at this in these applications, but the AI seemed to be on a trajectory to doing some types of things way better than a human being could ever do.
Yeah.
But some other things that are really critical, whether it's behavioral health or even some diagnostician stuff, where making decisions with incomplete information, often people are still able to do a lot better than the best AI because it leaps to wacky. The intuition factor doesn't seem to be there based on pure rationality.
Yeah, I think that's why several studies show that the combination of a human plus an AI tool and a human with experience, so an expert using an AI tool together is often outperforms either one because they're both bringing, the AI can bring certain insights that might not be immediately available to the human, and the human can fill in the gaps and understand the context in a way that the machine can't.
Yeah.
So that's my
Thank
my
you.
understanding.
Thank you, that's very helpful insight.
All right, I'm not seeing any other comments from the board. So again, I want to thank you, Dr. Schneider. It was a great presentation. I will see how it works out in the future, and maybe we'll have you back with more revelatory information. So
Stay tuned.
Stay tuned. So thank you very much.
Thank you.
Great presentation. We're about 10 minutes early for lunch, but we're going to break right now for lunch, and we should be back at. Do we want to start at 1:40 or just give it an okay, we'll be back at 1:40, so you get an extra 10. Woo! Oh yeah, that's right. Very good. get good extra time for lunch? I hope. Thank you. All right, good. Good. So right now we're going into fiduciary and Bagley-Keene training, and that's with Tiffany Reeves, partner at Faegre drinker, and Robert Carlin, CalPERS senior attorney, legal office. And good to see you, Tiffany. Good to see you, Robert. Weren't you just over here a little bit ago?
We ready?
We're ready to go.
All right, let's launch in. So hey everyone, I am excited to be here again this year in Monterey. We have another season of the Tiffany and Robert show. So I think the first season went well, so you invited me back for the second one, and I'm delighted to be here. So I just truly enjoy giving these trainings. I love teaching. It's I think one of the things I was put on earth to do. So hopefully this training will be dynamic and you will ask questions. I know all of you probably didn't wake up this morning and think, I can't wait to talk about fiduciary duties and the law. So it can be kind of a dry topic, but I'm hoping that we'll keep this engaged and more of an active discussion. Please do ask questions, interrupt me. I'll try to answer your questions on the fly. I have, one of CalPERS' best resources right next to me who can also assist with answering some questions that are specific to California law. And then if I can't answer your question on the spot, of course, you can always reach out to me down later and I'll get back to you as well. So just to kind of lay the groundwork today, we're going to start with some fiduciary duty basics. A lot of you have heard some of these issues before, but hopefully it will be a refresher. So we'll start with what fiduciary duties are, why they're important, and then we'll also focus on how fiduciary duties are applied. So we'll get into a few case studies. One of them will be a little bit spicy and interesting facts, but I really want to talk about how to make fiduciary duties tangible for you and how to apply them. So this presentation is intended to help you make the connection between what fiduciary duties are, why they're important, and then how you apply them, which is why I like to focus so much on governance, because governance is how you implement your fiduciary duties. So let's start with the basics. We'll try to kind of move through this this part a little bit quickly because I know many of you have heard this before, and also after lunch I really want to keep you awake. So luckily we're close, so I can catch you if you're snoozing a little bit. So start with the first thing is what is a fiduciary? So a fiduciary is a person who has the authority to make decisions regarding investments or to make administrative decisions related to the plan. So a fiduciary can be either a named fiduciary, so named in the statutes or the relevant statutes or the plan documents, or a designated fiduciary, so somebody who has been delegated fiduciary duty. A fiduciary is also a person who, by virtue of their function, either has a role where they're exercising discretion or has authority to make decisions with respect to the trust assets. So fiduciaries can be established by statute, policy, or contract. So for example, at CalPERS, fiduciaries include the board members, people who are board members who serve on committees. They also include your executives and certain employees who exercise discretion. They can include investment consultants, investment managers who you've delegated discretion to, and then any other service provider who has agreed by contract to be a fiduciary. So one of the things that I find as I travel the country and I travel even the world at this point talking about fiduciary duties is that the term fiduciary is a frequent source of confusion. And I find that the confusion about fiduciaries and what their role is and what duties apply is often just kind of an issue of semantics. The standard can mean different things to different people in different legal contexts, in different jurisdictions, and it does vary by jurisdiction slightly. And so I find that people often confuse and conflate fiduciary duties. So when you're talking about fiduciary duties, it's really important not to oversimplify. You should understand really the complexity and the different variances between these global legal frameworks and the duties that are applicable to different types of fiduciaries. So if you remember nothing else from what I talk about today, remember this. public pension fund fiduciaries in the United States are subject to the highest fiduciary standard under the law. Sometimes people ask me, well, I go to this conference and I met this foundation trustee and this is how they do it this way. Foundations and endowments are subject to different fiduciary duties because they have similar duties of care and duties of loyalty, but they also have the duty of obedience, for example, which requires them to be obedient to their organization's mission, so it's a supplemental duty. Corporate directors are also called fiduciaries, right? They have the duty of care, the duty of loyalty, good faith. But those are duties that are interpreted by state law. So generally, directors are required to act in the best interest of the corporation. Then you have investment advisors who are subject to the best interest standard, which is a principles-based standard that derives from the SEC's interpretation of the duty of care and the duty of loyalty. So, same word, different context, different frameworks, different applications, but the important thing for you to remember today is that public pension fiduciaries are subject to the highest standard under the law. And the key difference in the U.S. With the pension fiduciary standard is that there is zero tolerance for conflicts of interest. You have to act in the best interest of the participants and beneficiaries, period. So there are a number of sources of fiduciary guidance that help you to understand your fiduciary duties and apply your fiduciary duties. The first one is the California Constitution and the Public Employees Retirement Law. Your state constitution and your state statutes are the primary source of guidance on fiduciary duties. And then we reference a few other sources that are helpful in interpreting your fiduciary duties. So the first one is the restatement of trust. So when I'm referencing this presentation or otherwise trust law, I'm talking about the restatement of trust and court decisions that derive from that guidance. And so this is a treatise that all of the model codes that you hear people reference, Uniform Prudent Investors Act, are actually derived from the restatement third. ERISA is the Employee Retirement Income Security Act. That's a federal law that governs private pensions. So ERISA is not applicable to governmental pension plans, but it is a really useful source of guidance on fiduciary duties because typically courts, even under state law, will look to ERISA to kind of fill the gaps and to help courts to interpret the ambiguities in existing law. So ERISA is a key source of guidance, and I'll often cite ERISA cases because they're useful in that way. And then one important source of guidance is the practice of other similar fiduciaries, so other peer pension systems. And so often when you're thinking about prudence and what is a prudent process, an important part of that process is looking at other pension systems, looking at other similar fiduciaries and how they make decisions. It's not really dispositive of your decision, but it's an important factor in a prudent process. I mentioned model codes, and then the last source of fiduciary guidance is obviously my favorite, the advice of legal counsel. So you have your in-house counsel and your outside counsel. So let's move on to a discussion of core fiduciary principles. So as you know, there are a number of core fiduciary principles that are established by statute and common law, and we discussed them on the previous slide. But today we're going to focus specifically on the duty of prudence, which is often also referred to as the duty of care, and then the duty of loyalty, which includes the duty of impartiality. So generally, all of your core fiduciary duties derive from those two duties at the top of this slide. So, for example, the duty to diversify has actually been codified in California, and in many other states. But the duty to diversify is a principle that comes from the duty of prudence and really represents what was an evolution of trust law that evolved to accommodate modern portfolio theory and finding that it's prudent. It's almost always prudent to diversify investments, and so it was all kind of in the duty of prudence, but now it's kind of its own separate duty. Another important fiduciary principle is the duty to provide information, and this derives from the duty of loyalty. So fiduciaries should avoid conflicts of interest. They should communicate material facts to the beneficiary, and this duty also highlights the importance of transparency. You have the duty of cost management, that trustees should only expend trust resources for costs and expenses that are reasonable and for the purpose of administering the trust. And then obviously, trustees have a duty to comply with applicable law and the trust documents. We'll talk a little bit about co-fiduciary duties later. So the primary duty. California Constitution actually has this unique provision that says that the duty of loyalty is the primary duty. So the duty of loyalty, so the duty that the board has to its participants, will take precedence over any other duty. And this primary duty concept that's unique in California derives from trust law and was adopted in California specifically in an effort to prevent political meddling and other outside influence from interfering with the purpose of pension funds. So under trust law, trustees are expressly prohibited from investing trust assets in a manner that is intended to serve the interest of anyone other than the beneficiaries of the trust. So let's drill down a little bit on prudence. So the duty of prudence is forward-looking, and this means that fiduciaries are not judged in hindsight on an outcome from a legal perspective, right? You are judged in hindsight in lots of different ways. But from a legal perspective, a liability perspective, you're not judged in hindsight on the outcome of a decision. What you're judged on is the prudence of the process that was undertaken when you made that decision. So this means that the dissection of prudence is really contextual, which is why you'll hear me focus on process. I like to talk about the 3 Ps, process, process, process. Process and diligence is so important. What was done at the time you made the decision? Why did you do it? And how did that inform your decision making? So a key governance practice is in demonstrating formal and accountable processes of investigating material facts to inform your decision making. If there's a trustee who has a special skill or expertise, you're required to use that skill or expertise in making decisions. So if you are an auditor by trade, if you're a lawyer, if you're a banker, you're not supposed to kind of just check your brain at the door and just go along to get along. You're supposed to use that information to help inform your decision making. Under the prudent investor rule, delegation is permitted so long as trustees exercise reasonable care in selecting the agent, defining the scope of the delegation, and then continuing to monitor the agent's performance. I mentioned earlier that the prudent investor rule also addresses diversification. And then trustees also have to balance risk and return in light of the unique circumstances of the trust. This standard applies from a total portfolio perspective. So performance is evaluated on the total portfolio and not simply dissecting each individual investment in isolation. So California has a prudent expert standard, which has been interpreted by a number of cases in California. But basically what it boils down to is that trustees have to act solely in the interest of participants and beneficiary by exercising the care, skill, prudence, and diligence under the circumstances then prevailing that a prudent person acting in a like capacity and familiar with those matters would use. So we talked a lot, or even earlier, about process, and this is like this is a drum that I'm constantly beating. Prudence is a test of the fiduciary's conduct, not the result of that conduct. So courts are going to evaluate whether or not a decision is prudent, or when they're evaluating whether or not a decision is prudent, they're going to focus on the context and the process at the time that that decision was made. And that's why it's so important to have a robust and well-sequenced process. The process should inform the decision and not vice versa. And I've seen it happen in a lot of different contexts where it happens the other way around. You cannot reverse engineer prudence. You have to have the process in place to inform the decision. And then prudence is also dynamic and forward-looking. It has evolved over time. The restatement actually highlights this idea that fiduciary duties are flexible. It's not just stagnant at a point in time. Fiduciary duties and the application of fiduciary duties should continue to evolve as knowledge and circumstances change. The restatement actually cautions that fiduciaries should avoid the mistake of just freezing their rules against future learning. So you have to continuously rethink past assumptions and adapt to a changing environment. So with that in mind, let's talk a little bit about governance. So I mentioned earlier that good governance practices support the duty of loyalty and the duty of prudence. And I like to think about governance and fiduciary duties as two sides of the same coin. They're inextricably linked. And so formal and accountable governance practices and policies provide the guardrails that support decision-making and establish expectations in advance of a difficult situation. So I can't stress enough how important it is to establish the rules of the road before the crisis. So every kind of disaster that I've seen comes from people making it up as they go and trying to address a disaster in the middle of the disaster. It's important to establish the rules and policies in advance because that kind of helps guide you. So good governance is really that bridge between what your fiduciary duties are and the execution of your fiduciary duties. Good governance is the how in the process. It's the action. And the reason why I emphasize formal governance practices is because good governance implies formality. It implies structure, planning, foresight, and consistency of process. So let's get to the basics. What is governance? So at its essence, governance is the body of rules, practices, processes that facilitate the execution of fiduciary duties. So boards are a collective decision-making body. No individual director or trustee has the authority to take action on its own or to make unilateral decisions or to direct staff absent an express delegation. Good governance requires those formal structures, those effective policies, processes. And it's important to note that several studies have actually shown a return differential between good governance and poor governance. And so there was a couple of studies I cited on the bottom of the slide that shows that effective governance really results in outperformance from an investment perspective annually relative to peers. And although trust entities operate under similar laws and structures, and we talked earlier about peer practices, it's important to remember what my good friend Rick Funston always says: one size fits one. So each organization should develop its own policies, its own processes that are unique to the characteristics of that organization. One size fits one. So we look at peers to see what their practices are, and some other similarly situated investors, but ultimately it needs to make sense in the context that you're subject to. So let's talk about the duty of loyalty. The duty of loyalty requires trustees to act in the sole and exclusive interest of the beneficiaries. The duty of loyalty requires undivided loyalty. It's all about the beneficiaries, both current and future. It's all about the beneficiaries. The duty of loyalty also requires fair dealing. You have to deal with the beneficiaries fairly. There's no favoritism, and participants and beneficiaries need to remain reasonably informed. No self-dealing. This one's obvious, right? You can't act in your own interest. You can't line your own pockets. You have to avoid actual and apparent conflicts, and also avoid transactions that reasonably could result in future conflicts of interest. So one really common duty of loyalty issue is the two-hat issue, and you've probably heard Fiduciary Council talk about this issue over and over again, because it's something that we do come across frequently. And what happens is that fiduciaries, just as a practical matter, wear two hats. So you have the one hat that you wear in your personal and your professional life, and then you have the different hat that you wear when you come into the boardroom. And sometimes those lines can kind of blur, and this can be confusing when applying your fiduciary duties. So a board member might be a stakeholder, or they could also be a sponsor, or representing a sponsor, or be appointed by a sponsor. And so a common misconception is that board members can consider kind of this hierarchy of interest when they're making decisions. But it's important to note that the duty of loyalty does not permit the hierarchical consideration of different interests, period. You can't consider all these outside interests. When you're wearing your fiduciary hat, you have to be myopically focused on the best interests of the beneficiaries and nothing else. So, how does a board ensure loyalty? It ties back to good governance practices. Good governance practices that ensure loyalty include ethics and conflicts of interest policies, dispute resolution processes, and trustee discipline policies. Education and training, just like this today, right? Having fiduciary training, other types of training. Board self-evaluations, organizational culture, setting the tone at the top and consistently adhering to that cultural norm. And then audit and compliance functions are obviously quite important as well. So, as I mentioned previously, the duty of impartiality derives from the duty of loyalty, and it requires impartiality among individual participants and then vis-a-vis different groups of participants. It also requires income productivity, which means that fiduciaries need to invest, administer the trust to produce income reasonably appropriate for both present and future beneficiaries as a whole. The duty of impartiality applies to the total portfolio and not just individual assets. And so the bottom line with the duty of impartiality is that fiduciaries can't overlook the interest of some beneficiaries in favor of other beneficiaries. Beneficiaries, as you all know, are a diverse group of individuals and a diverse group of organizations within those structures. And they have very different present and future interests. And so they have different risk tolerances. They have different time horizons. When you think about a 24-year-old new entrant into the retirement system versus a 99-year-old annuitant, they have different exposure to future systemic effects of portfolio company practices. And so the duty of impartiality requires a really sophisticated analysis that recognizes and tries to weigh and balance all of those different interests rather than just kind of like merely like lumping them together and managing to the median interest. And so I want to note really clearly that the duty of impartiality does not require equality. It does not mandate equality. What it requires is this kind of careful consideration and weighing of these different interests to inform your decision making. And so one of the Supreme Court cases that was the first to address this issue is Verity v. Howe, which is cited on this slide. And in that case, the Supreme Court recognized that pensions need to preserve their assets to satisfy future as well as present claims and really take impartial account of all the interests of beneficiaries. And I always cite this case because it's one of the first cases that really recognize and reinforce the importance of time horizons. Pension funds have overwhelmingly long-term obligations, and because of that, long-term time horizons should almost always be considered and balanced in favor of balance with short-term needs. You guys are so quiet today. Last time we had so many questions. Not even giving me a chance to drink my water. So there are a number of different types of conflicts of interest. So we could spend like a whole training session just on conflicts of interest, but I'm just gonna highlight a few of the most common ones that I see in my work. and talk through those scenarios a little bit. So the first one is financial conflicts. This is the one that's the most obvious, right? You can't do things that are in your own self-interest. You can't line your pockets, and you have a number of different protocols in place for personal investments, gifts, and prohibiting other compensations. So that one's pretty straightforward. The second one is stakeholder conflicts. So you see plan sponsor conflicts arise frequently in the context of underfunding pressure. I understand you all are doing well, so maybe less sponsor conflicts or potential for sponsor conflicts arising there. But I come from Illinois originally, so where the systems are substantially underfunded. So a lot of times there's this kind of push-pull where the employer is wanting to reduce a payment or delay a payment in order to meet budget goals, but obviously that's not in the best interest of the plan. So you see a conflict where there's a pressure to make politically motivated decisions, and politically motivated decisions regarding investments, politically motivated decisions regarding actuarial funding levels, et cetera. Serving two masters is always a good way to disappoint both of them. And it's just a breach of fiduciary duties. You can't have that divided loyalty. So plan sponsors, unions, beneficiary groups, they're always going to have strong and often conflicting opinions. But as long as you're really focused on what your core mission is, the best interest of the members, you can avoid these conflicts. Employment or professional conflicts. If your day job benefits from your board role, that's not alignment, that's a fiduciary risk. When you have a dual role, you have to be really mindful of this. You have to make sure that you're wearing the right hat at the right time and considering only the interests that are relevant to the hat that you're wearing. And then obviously employment with a vendor is prohibited, and there are also post-service restrictions. Another type of conflict is political or organizational conflict. This is this external pressure that you may get to align or act in connection with the interests of an external group or special interest group. But remember that in California, the Constitution includes that primary duty rule that was enacted specifically in an effort to avoid that external meddling or the voice of special interest groups in pension affairs. Family and close personal conflicts of interest. This one's pretty straightforward. You cannot indirectly benefit yourself through a family member. You have to avoid nepotism. I was in-house myself at a pension fund. You would be surprised at the things that people ask of you, and I'm seeing some nods. It's pretty amazing the pressure that you can get from the outside. I always think it's funny because when I was in-house, I thought I was like super charming and everybody wanted to talk to me. But when that government email went to Gmail, I was no longer as charming as interesting. People are interested in you when you manage a lot of money. And even family members may ask interesting things. And so it might make Thanksgiving a little bit awkward, but you have to have a boundary with family members and really avoid those personal conflicts. And then the last one is use of confidential information. You cannot use information that was gained in a confidential context through your board role for any other purpose. So this next slide talks a little bit about different cases involving conflicts of interest, which can take a number of different forms. But the bottom line is that when making a decision, if it's influenced by anything other than the best interest of the beneficiaries and participants, you've got a problem. And so trust law really requires that unwavering duty to beneficiaries at the exclusion of the interest of all other parties. So here are a few examples. I'm just going to touch at a high level on these cases interpreting the duties of fiduciaries. This first one, O'Neill, is a California case. And in this case, there was basically a dispute involving certain board decisions related to actuarial assumptions and also funding reserves. And the court in this case highlighted that a fiduciary has a duty not to use or deal with trust assets for the benefit of a third person, including the plan sponsor in this case, which was the issue. NLRB versus Colmax is or Apex Coal. I always say Colmax for some reason. It's in my head. It's kind of an older case, but this is a Supreme Court case that really highlights the rule against divided loyalties. And then these last two cases, one of them being more recent, is an ERISA case. And remember, ERISA is not binding on governmental plans, but it is useful guidance. And both these cases dealt with the breach of the duty of loyalty due to the influence on the board of other interests in their decision-making process, and so a consideration of other interests in their decision-making process. So I want to take a deep dive on the next slide into a more recent case. This one comes from late in 2025. And I think it's really relevant to this discussion. So I want to pause on the slide because I think here's where you really get some concrete examples of moving from like these fiduciary duties theories to the consequences of failing to act in accordance with fiduciary duties. So to set the scene in the context for this case, the facts arose in an environment that was very low trust at the time. And so it's an environment where the stakeholders and certain special interest groups were really unhappy about a number of issues that were happening at the time. But most notably, the issue was this cost of living adjustment. It had been suspended for a number of years, and as you can imagine, the retirees were not happy about that. And so amongst other issues that were happening, people were angry, tensions were heightened, and there was just a general environment of mistrust. So that's kind of the perfect storm for what eventually happened in this case. And so in that context, there was this new asset management firm called QED. And the firm reached out to the board chair and basically claimed that they could solve through the COLA problem through their very innovative investment strategy that was new. Sounds a little suspicious to begin with. And so although it's not the typical process, the board chair referred the new firm to the CIO, and the CIO and the outside consultant conducted a diligence on the firm, and they basically decided to take a hard pass. The CIO called the investment firm a desk kill. He said, basically the firm had no assets under management, there was no track record, they weren't registered with the SEC, no formal business plan, no clients. Pretty easy, Stephen's nodding, from a diligence perspective. Pretty easy to take a hard pass on that, right? Nonetheless, the board members, there's two of the board members that continued to engage with the firm. And so the evidence in this case showed that two trustees continued to communicate with this firm in secret via text message, email, and then eventually on Signal chat over a period of time, actually a couple of years, I believe. So including communicating with the principals of this firm, and even being instructed by the principals of this firm during board meetings. In these live communications on Signal during board meetings, this outside firm even instructed the board members on what motions to make, and the board members made the motions. But despite all of these efforts and manipulation and really kind of efforts to intentionally drive a wedge between board and staff, the board as a whole did not support the proposal. But the problem was that the board, after that, they didn't put it to rest. These two board members, they just continued down this path, kind of beating the same drum. And the board was really unable to move forward in a unified direction, and it created a lot of dissension and chaos. And I can't really speculate as to what the ultimate motive was, but the problem continued, and the CIO described it as it seemed like it was aimed at really kind of poisoning the well. And in certain respects it did. Several staff members resigned. The outside investment consultant resigned and decided not to renew their contract. And then there were several complaints filed with the Ohio Ethics Commission. And when some of these facts came to light, ultimately it led to a lawsuit. So the AG of the state of Ohio sued the two board members, or the one current and one former board member, alleging that they had violated their fiduciary duties in connection with their dealings with QED, this prospective manager. So The core allegation in this case was that rather than acting exclusively for the benefit of the members of the fund, these two trustees really aligned themselves with the interest of this investment firm. And the court found that the facts showed that these trustees coordinated with QED and had these back-channel communications. They shared confidential information with this firm. They advocated for QED's investment proposal in a way that truly compromised their independence. And then they even had this outside firm ghostwriting communications to the board, to the executive director, and to other staff members. So although the two trustees claimed that the reason why they were coordinating with this firm was because they really believed that this strategy would help reinstate the COLA, the court found that it doesn't matter what they believed the strategy would do, that they had in any event breached their fiduciary duties. And in its analysis, the court noted that the issue was not simply why the trustees wanted to act, but the issue was how they went about it. And the court found that the trustees breached their duty of loyalty. The court said that they demonstrated at best that they had a split loyalty between the participants of the system and this outside firm, but ultimately that these trustees were really acting as agents for undisclosed principals. The court also found that they breached the duty of prudence. The investment idea had been rejected by the experts. It had been rejected by their internal investment team. It had been rejected by their consultant. And as I mentioned, no assets, no track record, no registration, no nothing. Yet the trustees continued to pursue this strategy even after the board declined. They also breached the duty of transparency. The court was really focused on these secret communications, the signal messages, the ghost written emails and communications. The failure to disclose to their fellow trustees where they were getting this information. And then also the failure to disclose that the source of the information driving the whole QED discussion was coming from QED. And then finally, the court found that the trustees breached the duty to follow their governing documents. They didn't follow their established protocols. They didn't do anything that followed the process. It was all kind of working around their processes. And so this case is a really important reminder that policies matter most when the pressure is highest. This is exactly why I keep coming back to governance. The process has to be defined, defensible, and transparent before the hard issues come through the door. And you have to follow your own processes. These board members did not follow their process.
Tiffany?
Yes.
I do have a question.
Mm-hmm.
What happened?
Oh.
Is that the next page?
Right there, it's right there, the outcome. So this was just in November of this year, last year, 2025. The court found that the two trustees had breached their fiduciary duties and they issued equitable remedies. So the former trustee was permanently barred from serving on the board, and then the current member, who was the chair at the time, I believe, was removed from the role of trustee. And so I think there's a number of important takeaways from this case that are direct takeaways, but also that are worth kind of like just sitting on for a moment and considering. And the first one is that personal accountability is real. The remedy is not just a risk to reputation. The remedy in this case was that these trustees were removed and banned from serving by court order. But the other issue is monetary damages. And so monetary damages, money damages were not in play in this case because the AG actually amended the filing, I'm not sure why, to take that off the table. So initially they asked for money damages and then they took it off the table by amending the complaint. But there is certainly potential for personal liability in this type of case, and personal liability that likely would not be entitled to indemnity. The other takeaway is that Attorney General enforcement can be an actualized mechanism for enforcing fiduciary duties. So fiduciary duties are enforceable obligations. They're not just aspirational standards. And so in this case, there was a direct statute that permitted the Attorney General to take this action, but oftentimes fiduciary duties can be enforced through lawsuits and participant lawsuits as well. So there are mechanisms for enforcement. The exclusive benefit rule matters. Political, personal, organizational, and even vendor motivations are problematic, even when the stated goal, and the stated goal in this case was that they thought that they were helping the beneficiaries. Another key takeaway is document decision-making. The board's process, rationale, diligence, and disclosure record should be capable of being defended even after the fact. In this case, the back channel communications, the process workarounds, the lack of transparency of these two trustees clearly gave the appearance of impropriety, and they really undermined trust and the effective governance of the board and their ability to operate. And then the final key takeaway is that outside meddling in fiduciary decision-making has very real consequences. The bottom line is that undisclosed influence can create very real legal and governance consequences for individual trustees and also for their retirement system. So when we turn back to the restatement on the next slide, I'm hoping that this will feel a little less abstract in light of this case study. The law is not just concerned with whether a fiduciary can articulate a good goal. It's concerned with whether the fiduciary's motivation and process and conduct stay focused on the interest of the beneficiaries. And that also applies to trustees' personal views or political views or social views. And so the restatement says that trustees cannot be motivated by a purpose of advancing even their own personal views or their own social political views. So moving on to governance a little bit more, I included this slide for the sake of completeness and as a reminder that CalPERS has a number of policies related to board members and CalPERS team members and to help board members and CalPERS team members to comply with their fiduciary duties. And Robert can be a great resource for you if you have any questions regarding those policies. But you do have a robust governance framework, and so it's important to understand what your policies are and how they're applied. So how does a board ensure that it's complying with their fiduciary duties? This brings us back to my favorite framework. What, why, how? What are you doing? What is being proposed? Why are you doing it? Or why would you do it? If your answer to why is anything other than it's in the best interest of the members and the beneficiaries over the time horizon that we've deemed to be material, then you likely have a fiduciary problem. And then finally, how? Are you conducting your diligence? How are you implementing the chosen course of action? This is the process, the 3 Ps, process, process, process. And it's your obligation as board members to ensure that your process is prudent. So, the last topic of the day is co-fiduciary responsibilities. This is a topic that I like to talk about because I feel like you don't hear it too much in standard fiduciary trainings, but it's important for board members to know that board members owe a duty to each other and can be held liable for the conduct of other board members. The co-trustee responsibility concept has been derived from court cases and is even codified in certain states. And basically it requires board members to actively participate in the affairs of the trust. So this duty is both a right and also, it's both a right and also an obligation. So trustees generally cannot be excluded from decision making. Co-trustee responsibility requires reasonable cooperation. This means that trustees are required to maintain effective working relationships. It requires a basic level of civility and decorum among trustees. And then trustees are also required to self-govern and can be held liable for the conduct of other trustees. So if another trustee commits a fiduciary breach, the other trustees should take reasonable steps to remedy the breach. There's only a few cases on co-fiduciary liability, but I cited this Ball case here because I think it's important to understand that the court here emphasized that co-trustees have a responsibility to conduct themselves in a manner so as to foster a spirit of mutual trust, confidence, and cooperation to the greatest extent possible. So you're a self-governing body, and you own the conduct of the body as a whole. So that's the context of co-trustee liability. So it's also important to remember that the board acts as a collective body, not as individual actors. This whole governance construct is designed to provide for intellectual diversification and collective knowledge, which is really viewed as preferable to individual decision-making. And so even in a sole fiduciary governance model, which they have in other states in the US, there's an advisory board, there are guardrails that control for risk and really account for the limitations of individual knowledge. And so each individual director has the obligation to act with care, loyalty, and good faith, but no individual director has the authority to act unilaterally unless they've been delegated that authority formally. So with co-fiduciary duties in mind, let's discuss some of the behaviors that support high-functioning boards, and then kind of the inverse of that, some of the behaviors that should be avoided. So what are some effective board behaviors? You know, the first one is listening actively with an open mind, including an awareness and a consideration of how bias can affect decision-making. Showing respect for co-directors, executives, and employees. Some of these seem really obvious, but it's really interesting when you see this not happening too. And I have, in my 20 years of doing this work, seen really poor functioning boards where even basic levels of decorum are not present. Ask constructive questions. Promote discussion and debate, including the exercise of self-control. Maybe some of you have been in circumstances where you know, somebody can take up all the oxygen in a room and not leave little room for others to participate in the conversation. It's important to exercise self-control and, you know, say what you need to say, be concise, and then let the discussion continue. Commit to working towards consensus after an effective and deliberative process. That doesn't mean that you can't have vigorous debate and differences of opinion. It just means that when it comes time to making a decision, you try to work towards more consensus after an informed and deliberative process. Sometimes you might dissent, and that happens as well, and that's okay. But the goal is to move towards consensus. Support and not undermine board decisions once they've been reached. The Ohio case is a perfect example of that the board made a decision. And once the board makes a decision, it's important to move forward in a unified direction and not continue to revisit past decisions unless there are some changed circumstances that would require that. Identify and disclose conflicts of interest and recuse yourself where appropriate. Protect board confidentiality. Avoid speaking on behalf of the board without authorization, and then raise concerns in an open and transparent manner. And then the inverse of that, what are some problematic board behaviors? Failing to abide by board policies and protocols like you saw in the Ohio case. Abrasive, abusive, or disrespectful words or actions. Monopolizing discussions. Unduly interfering with management operations and delegated discretion. Staying in the lanes once they've been established is important. Overstepping one's authority, leaking confidential information, failing to disclose a conflict of interest or acting on a conflicted basis, and then the failure to comply with laws or regulations. Remember that boards are self-governing bodies. You collectively set the standards for behaviors, and you set the tone from the top. You hold each other accountable for the norms of your body. And high-performing boards and organizations achieve alignment through clarity, through culture, accountability, and consistency. So clarity about the rules of engagement, understanding what their rules of engagement are. What are the expectations? What are the behavioral norms? And defining kind of those structures and practices. Culture, setting the tone from the top. Remember, I think I said this last year as well, your culture is defined by the worst thing that you tolerate. The board owns its culture and has to hold each other accountable for those behavioral norms. Accountability involves self-governance, controlling the controllables. Boards are collectively responsible for their own effectiveness, and the board has to model its culture and hold its members accountable to the policies and behavioral norms. And then consistency, including all of the above, right? High-performing boards achieve alignment by consistently doing the work day in, day out, repeating the processes, even when nobody's watching, following those policies and procedures. So just to wrap up my comments, remember that good governance practices are the how. Governance is really the bridge between what your fiduciary duties are and executing your fiduciary duties. So governance is that mechanism through which fiduciary duties are applied. But good governance is not a panacea. It's not going to cure all ills. There's always going to be externalities, personalities, and circumstances that challenge a board and that challenge an organization. You cannot possibly predict the future, but what you can do is make your organization more resilient. And good governance really helps insulate boards and other fiduciaries from personal and collective liability. So today we've covered statutes, we've covered structures, and then several interesting cases, but the bottom line is that fiduciary duty is not about having a crystal ball. That's not expected of you. It's about a disciplined process, documented reasoning, and independence when it matters most. Markets are going to shift, politics shift, but your fiduciary duties are the same. And courts do not demand perfection. They demand loyalty, care, and process that can withstand uncertainty. So that's the standard. And I'll leave you with that. And Robert is going to talk a little bit more about the Bagley-Keene Act.
Thank you, board members. It's great to be with you here again this year and this afternoon. Tiffany mentioned that fiduciary training right after lunch was risky. Well, Bagley-Keene after lunch is, I think, even a little bit more dry, but I will do my best to keep it lively and interesting and go through it promptly. So today, just a brief roadmap of what we're going to be talking about. We're going to do a quick overview of the Bagley-Keene Open Meeting Act, which I know all of you are very familiar with now, but it's always good to go over the fundamentals. And last year, at this time, we went over the serial meeting rule in a little bit more detail. This time, we're going to go a little bit over something that's been talked about occasionally over the years, but specifically how Bagley-Keene applies to member appeals and when the board sits in its quasi-judicial capacity to make decisions about those. So Bagley-Keene applies to all meetings of state bodies, and a meeting is any congregation of a majority of the members at the same time and place to hear, discuss, or deliberate on something within the subject matter of CalPERS, which is a wide purview, as you all know. A state body is the board itself, created by statute, committees the board creates, and any subsidiary bodies that the board delegates authority to, subcommittees and things of that sort. The Bagley-Keene's requirements, which you're all familiar with, require that we give 10 days notice to the public of the meeting. We have to publish an agenda that gives, essentially the standard is fair notice to the public about what's going to be what's going to be discussed at the meeting so that there is an opportunity for them to either tune in over the web stream or attend the meeting if they want to provide public comment, or to call in if they want to provide public comment. The default is everything that's done by a state body like CalPERS has to be done in open session unless there is a closed session exception that allows the board to meet in private to discuss it. We discussed the serial meeting rule last year. That's essentially, you could think of it as the backstop that ensures that you're not indirectly doing something that should be done in the meeting. So when a majority of the members outside of a meeting are discussing something, whether one to another or in groups, that's potentially when we get into serial meeting danger zone, and we want to be careful about that. For a number of years now, post-COVID, we've been living in the reality of remote meetings from time to time, and the ability for some members to participate remotely. At one point, we were all 100% remote. That was only possible because the governor issued an executive order at the time that suspended the operation of Bagley-Keene. The traditional teleconference rules are somewhat onerous, which is one of the reasons why teleconference meetings before that were particularly unusual, because any other teleconference location had to be publicly noticed. Members of the public had to be able to have access to it and to provide public comment from it. And so it made it challenging. Now, under statutes that have been passed in light of COVID, there is some ability for a minority of the members of the board to participate from a remote location. That exception is in place through 2030 right now, so that's the rules we're operating under right now. And so as long as a majority of the boards are physically present in a particular location, it's possible for a subset of the board to participate remotely from a private location like their own home without having to have that location identified and things of that sort. The closed session rules allow for certain limited topics to be discussed in closed session. We can consider investment decisions. You can receive advice from your legal counsel related to pending litigation. We can discuss things related to the health plan benefits that we've been doing. Things of that sort are covered. A key part of Bagley-Keene is a role for the public, both to be able to attend and to be able to provide their comments, and that's enshrined in the law. But there's some interesting qualifications to that. We generally have to provide public comment for each particular item, but a state body retains the ability to regulate public comment, and that's partly a recognition of the fact that a meeting is here not just for public participation, but in order to carry out business that's been delegated to this agency by the state of California, in this case, to run the retirement plan, make the investments, and do all those kind of things. So it's a recognition of that balance there. In 2016, CalPERS adopted a regulation to codify our longstanding practice of a 3-minute time limit. So that's in place there. I provided some information about that on this slide. Now, interestingly, this is my segue into the part about administrative adjudication. There's some clear exceptions where Bagley-Keene recognizes public comment is not applicable. And one of those happens to be when the board is sitting to make a decision about an administrative law judge decision. And that makes a certain amount of sense, because when you're sitting as a judge in a particular case, public opinion is not one of the things that you're supposed to be considering. And so the law delegates authority to the board to be able to hold a hearing. And there's, when it comes to member appeals and things of that sort, and there's an interesting sort of tie-in to the general fiduciary principles that Tiffany was talking about and that you're all familiar with in this context. And that is that the law does not expect or contemplate that any of you are going to have previous judicial experience when you come on this board. And part of the way that that's enshrined in the law is that there is an administrative law judge generally who is the person in the first instance who has legal training, who knows the rules of evidence and things of that sort, and who is the person who is hearing the member's appeal in the first instance. And as you're all familiar from our monthly meetings, the result of that process is the administrative law judge issues a administrative decision following the member's appeal, and that administrative decision comes to this board for its consideration. And once that happens, the decision has been issued, the board has 100 days to take action on it. If you fail to take action on the decision, it becomes effective automatically. It goes into effect. And what the law recognizes your ability to take action on a decision. You can adopt the decision, you can make minor technical changes to it and adopt it. You can reject it and remand it. We typically refer to that as remanding it back to the administrative law judge for the taking of additional evidence. Or you can reject the decision and choose to have a full board hearing and hear the matter yourselves in your own instance. This goes to kind of some of the important key issues about how to conduct yourselves when you're in a quasi-judicial capacity. Because we're dealing with members' vested benefits, members who have met the qualifications for a retirement benefit and have earned their retirement benefit, those kind of questions implicate a property right. And the law basically recognizes that there is procedural due process that must be upheld for each member's benefits to ensure that they are not improperly being deprived of a property interest. And so what the law demands when there's a hearing to address that kind of topic is an impartial adjudicator. And that's what your role essentially is. This is sort of recognized by what is referred to, informal at least, as the exclusive record principle. The idea there is what you're looking to is the decision from the administrative law judge, the findings of fact that they've made, and the record that's put forward before you. Nothing else is relevant to you making that initial decision. Another key component of satisfying procedural due process for our members, and this goes to why we have Chirag Shah as the board's independent counsel, is what I call a separation of the adjudicatory and prosecutorial or investigative functions in the agency. The basic idea is when you're sitting as the judge, if I'm advising, for example, if I were advising or Pursuant's advising the team who's doing the investigation, I shouldn't also be the person who's advising you directly on how the law applies to a particular case. That would sort of interfere with the impartiality. And so what Chirag provides is an independent counsel who has not been involved in any of that sort of thing and is there purely to advise you on the law and the legal issues involved in a particular case. Another aspect of due process is the avoidance of ex parte communications, basically communications from interested parties, whether it's the member, somebody who's on the member's side, or somebody who's averse to the member, communicating with you outside of that process. And again, that's why it's important to focus on that exclusive record. That's what's before you. That's what you need to refer to. And in a situation where you potentially have some bias or there's a potential conflict, that's where recusal is an important part of it. And I think it's helpful to contrast the process that we follow when we're doing an individual adjudication from the process to adopt a precedential decision. A precedential decision is essentially a situation where, based on usually staff's recommendation, a particular case very poignantly illustrates the facts and the law and its application in a way that's likely to recur in multiple cases. And what the board can do, and the law authorizes the board to do, is to make that decision precedential so that it both governs in future similar cases when the facts and the law are the same, and it helps to inform the public, and it's a useful tool for staff in administering the public employees retirement law. That is the end of this part of the presentation. Happy to take any questions about this or anything from Tiffany's presentation.
So I'm going to start with you. I have people that do want to ask questions. Something came to my mind when you said that impartial adjudicator. So say it's a retiree from SEIU, but SEIU wants to see this changed for for people that retire, and they've called me. Do I have to, what do you call it, recuse?
When you say, like, call you in the context of a particular member decision?
Yeah.
I think what I would say is it's not improper to have gotten that phone call, like when they reach out to you, but what I would tell them is, I can't talk to you about this right now because when it comes to this particular case, I have to be focused just on the members, the record, the proposed decision from the administrative law judge, and you can ask Chirag for advice on how the law applies to the particular case, but that's really got to be the hallmark of what you're focused on. At that point.
Yeah, I never ran into that, but I just wondered, it brought that to my mind. Okay.
Good question.
Yeah.
I had two questions for Tiffany, but following your question, is there a subcommittee of this board that reviews those administrative? No, we just all get everything and
first?
yeah.
I'm sorry.
Okay.
It goes to Chirag first.
Okay.
and he reviews and makes a determination, and then tells us what his determination is, but we don't have to follow that either.
Okay. Right. Okay.
So it's definitely different than CalSTRS, which you're thinking of, which has its own separate appeals
Yeah.
committee that deals
That's
just with that. That's exactly right. We have, CalPERS has never done that, and it's a
And we
full
shouldn't.
board matter at
Okay.
present.
And then my two questions for Tiffany. One, it relates to your comments on governance and your statement that the board acts as a collective body. Corporate boards typically develop a skills matrix and fills out that matrix to make sure that we have the right skills as a board as a whole, but we don't really have that option here because members of the board come from different constituencies. What is our responsibility as a board to make sure that we have some of those gaps filled?
So a lot of times,
You just weren't close enough.
a lot of times, what boards do is, periodically do self-evaluations and understand kind of what their skills are and what their gaps are, and understand what the opportunities are for further training in that regard. And then also, when there are key decisions that are coming up, and I've seen you all do this as well, do a series of board educations to help inform how you make those decisions. So every board does it differently, but I do see boards do periodic self-evaluations, and then to kind of determine where their gaps are, and then do guided self-learning with that as well. Other times too, I've seen boards work with an appointing body to say, hey, we've identified kind of a need to have a certain expertise on the board, and sometimes appointing bodies will be mindful of those needs when they're making those decisions.
Okay, thank you.
So can I add to that? So I had brought up in one of our governance meetings to have self-evaluations. The board members did not like that idea. So skills assessment. We're doing the self-evaluation. That's an every other year thing that we do anyway. That's different. That's more of a how's the team doing type of thing. But I remind everybody that we are an elected board. A lot of us are elected. There's 6 electeds, and then some of us are appointed. And so people know that we're a lay board. So our staff helps educate us, right? So when we're making decisions on stuff, because none of us come, maybe you do, I think, come with an investment background. Some of us have a little bit of healthcare background. I do, some other people do, but we all come from different walks of life, and a lot of it had to do with leadership rather than anything else, right? So I think that to add on to what you're saying, as long as we're getting some kind of training, and then we have our own board training. There's lots of the International Foundation of Employee Benefit, et cetera, is a really good place to get your training and your certifications. So I think we have the opportunities to do that, but CalPERS is really also very, very good at making sure that if we're like, oh my God, I almost said taxpayer folder, TPA, we went through a huge amount of training for that so that we could feel confident enough to make that decision. So I just wanted to make that clear before Deb asked another question.
Okay, thanks. And then the second question was about your statement that we should operate in the best interest of the beneficiaries. How do you define that? And when we cannot put one set of beneficiaries' best interests ahead of another, there may be different constituencies in our membership that believe certain things are more important than others. So how do we navigate that to be able to operate in the best interests of our beneficiaries, knowing that it's not defined by one goal?
That's a really important question, and I think that's the key question, is that you need to have all the information and consider the interest of all those beneficiaries. And why I mentioned that the law doesn't require quality. What it requires you to go through is a process of considering these interests, comparing them to these interests, and making those decisions that are in the best interest of those beneficiaries as a whole. So the law doesn't require that you cater to any particular interest. It requires that you go undertake this sophisticated analysis to weigh those different interests, overlay that to your time horizons that are relevant, and make those difficult decisions. And if it were an easy decision, everybody would sign up to be a trustee. It's a very complex and difficult decision-making process, and it's, I think, challenging to talk about it in abstract, right? But when you have a specific issue, that's something that I assist with, legal counsel assists with, that different experts assist you with, kind of weighing all those different considerations and coming to the right, to an appropriate decision.
And just to follow up, a set of beneficiaries in one state may not have the same best interests as a set of beneficiaries in another state, for example. So in California, we have a very different set of priorities and goals and interests than a beneficiary in Texas might, for example.
Absolutely, it's a very contextual decision. Absolutely. I mean, that's a very abstract question, but yeah, it is contextual depending on what the issue is.
I'm trying to make it abstract, actually.
Yeah.
All right, thank you.
I would just add that I think a good way to think about it is it's not the overall interest of the members, but it's their interest in providing their retirement security. That's the goal that's ultimately anchoring and driving what we're doing here. And I think
But where is that written? That retirement security is what?
in the Constitution, in the Pearl. I mean, the reason why the board has the authority it does, and we have the power that we do, is to make sure that we are providing for those benefits in the long term. Recognizing, I mean, you're raising a great point. You have a retiree population that is no doubt very concerned about capital preservation. You have active members who are concerned about how much their rates are, and your job is the difficult job of balancing that out, those different interests. And I think a good way to think about it as a tangible, practical matter is it really comes down to, as a fiduciary, making it the important delegations that you do, delegating authority and hiring competent actuaries, competent investment staff who can properly assess all those issues for you and then bring those facts to you so that you can make a decision about what's the discount rate going to be, what's the investment mix going to be, and all those kind of things.
Thank you.
Okay. I'm sorry. Gail?
Yes. First of all, I would like to commend you on your presentations. Very excellent. Did a good job. My first question is for Tiffany. The fact that several studies have exhibited effective governance practices can improve public pension investment returns by 1 to 3% annually. Can you provide more clarification on these findings by giving specific examples? Robert, your question is, after 2030, will members of a board be required to attend meetings in person?
Why don't I take that one first, because that's the quicker one. The answer is unclear. It was originally set to expire in 2026, and the legislature extended it out to 2030. So my guess would be, if I had to prognosticate, it will be extended again for another 5 years if we haven't moved to a more remote natured process to begin with itself.
A less remote, you mean?
Or more opportunity for remote participation.
Oh, yeah.
I think
if we move to less remote, it might get taken away.
Yes, correct.
Thank you.
Yeah, so I'm not prepared to talk about those specific studies, but I can give kind of a more, and I also can't obviously talk about anything that's not public, but I think that Ohio Stirs is a perfect example of how poor governance can impact performance. And so when you have poor governance practices, when you have external investigations, when you have leaks of confidential information, when you have drama, it impacts the ability of the board to focus on its core purpose. And it also expends trust resources with dealing with other issues, with dealing with audits, with dealing with media, with dealing with even, there's been other situations that are public with one of the Pennsylvania retirement systems where there were a number of investigations where the SEC was involved, and even where there were local government investigations. Those really divert your focus away from your core mission, which is investment. And then also, I can just speak personally from being in-house myself, is that when you have drama, how much time have any of you had spent, an hour on an email just to have the appropriate tone, and so it's not received in a certain way? That's an hour that I could be spending as an in-house professional at that time doing things that benefit the trust rather than managing the drama. And so that's where poor governance comes in as well, as it really diverts the focus of your in-house professionals as well.
Excellent. Thank you so much. Appreciate it.
Miss Yvonne?
Thank you. So Gail got me on one. The 2030, I was like, got a sunset, let's fix that. But I want to go back to drama, because I make a distinction between drama and a robust discussion, right? And my standard has always been, and I've always thought it was right, of course, because it's my standard, but that you can have a robust discussion, but once the board has made a decision, that then becomes my decision, right? Regardless of how I might have felt pre-vote. So is that, because I don't want us to confuse robust discussion with drama. It's not. It might appear drama. Some people might think it's drama. They might feel like it's drama, but it's not. And I think that is something that should be encouraged or required of us, to have a robust discussion. We're not all coming from the same place. We don't all come from, we have different expertise, and everything else. And I thought that we're supposed to bring that to the table.
I think that's right. I heard somebody the other day, I was listening to a podcast or something, and a psychologist was talking about healthy heat. And I like that word, healthy heat, right?
Right.
Healthy heat is important in an interpersonal relationship. Sometimes you disagree,
and it's okay.
You have to work through it, and that's okay. And I've also seen the inverse of that be true, where people were too polite to ask the questions that they had, or even where a board member was, too unsure to ask the question, and maybe other board members could have benefited from it, but they were like, were worried that they might sound uninformed if they asked the question, and so they might ask it in a different context. And so there should be debate in certain circumstances where people express their opinions, ask their questions, but when it's time to make the decision, and once the decision is made, even if you dissent, then you move forward in a unified direction and not continually to revisit it. And when we're going back to poor governance and how it impacts performance, I've been in scenarios where a decision has been made and then you spent months revisiting it and revisiting and revisiting it, and that's not useful unless something has changed. Even if you care really deeply about that issue, it's time to move on.
Okay.
It's not productive now.
Yeah. And then I had thing on when we sit as the judge, right, for the decisions that come, and we have people that come and talk to us, do the time limits stay the same, or?
That's a go ahead.
Well,
when we have the member appeals originally come to you, you have a proposed decision before you, there's no ability for oral argument or public comment either from the member themselves or from staff. When you have a full board hearing, I'm not going to be able to give you the exact specifics, but there are set times in policy for how much time each side will have to make their case before the board. And that's in the situation where you've rejected the proposed decision and decided to hear it yourselves.
It's like 5 minutes, I think. We haven't done one since.
It's been a while.
For over 4 years, I think.
Yeah. My colleagues in the other part of the legal office would be able to give you those specifics, but I'm not going to try to even pretend to know them.
And they will tell you ahead of time, so you don't have to worry about it. Any other? Oh, Ramon, go ahead.
Thank you. I have a question on the fiduciary duty. On the state constitution, of course, it's about the beneficiary, the parties of the beneficiaries. But there's also a clause about defraying reasonable expenses for administrating the system. And that have always struck me as interesting because one, it clearly is not a priority, but it's there for a reason. So then the question is, if it's there for a reason, when do we consider it? And if we do consider it, it said reasonable expenses for administrating the system, is that the cost to the pension fund, to the plan sponsor, or to the member? Because the retiree doesn't pay anything, it's already paid.
Right.
So that I always thought that was
You
interesting.
look like you had something to say, so I'll let Robert supplement, but it's the expense of administering the system itself, right? And so, you know, your obligation is to make sure that those expenses are reasonable, and so you're not incurring, you know, outsized expenses without, you know, a corollary benefit. Now, that doesn't mean that you have to always hire the lowest cost providers, you know, and operate, with substandard providers just because they're less expensive. But it does require you to have oversight over the expenses of the system and make sure that the processes are in place to make sure that they're reasonable.
So based on your answer, it could be something like, are the fees reasonable, right, for
Correct,
whatever
yeah.
return? So does it at all apply to actuarial assumptions where there may be one or two reasonable assumptions and the discount rate? For example, a board in Southern California a couple of weeks ago lowered the discount rate, which impacted the funded ratio, impacted the employer contribution, and perhaps the employee contribution, member contribution, if they were PEPRA members. So would that apply as actuarial assumptions?
I'm not sure that I quite understand the question, but let me finish the first response, and then I'll see if Robert has anything. But I wanted to put a finer point on there has been tremendous litigation on the ERISA side addressing the reasonable expenses as well, and just how important it is that a board a board and other fiduciaries don't just make a decision at a point in time and just set it and forget it. That they have
That's for the defined contribution plans,
yeah,
right?
exactly, but it also
Right.
provides you with guidance that you have an ongoing obligation to monitor expenses and make
Right.
sure that they're reasonable, and so it's not just a moment in time. The reasonableness of them has to be contextual. In terms of actuarial decision-making, the only thing I would say about that is that that's an area, you know, among others, where it's really important to listen to the experts, right? And so in addition to not having the specific expertise that President Taylor was talking about, it's also about time as well. I mean, you hire experts for a reason. And if you were to make a decision that's contrary to the advice of your experts in that field, like an actuary, for example, you should have a reasonable and informed
But
basis for doing that.
Actuaries sometimes give you two options. Like in health plans today, we have three options out of a possible 8,000. So there is what you call reasonable solutions.
We did it too, Ramon, before you were here, and it was to actually save the system. So that has to be, you have to look at what they were trying to accomplish, right? So we lowered the rate of return, and then we instituted every time that we beat the rate of return that we would buy the rate down, which is how we got to 6.8.
I know,
but it's the same reasoning. It would be to make sure the system is fully funded.
Fully funded is, I'm big into funding.
So I'm sure we would have to know, you'd have to know the particulars, but it wouldn't, I don't think it would, as long as your staff is telling you it's going to help you, I don't think it would fall under unreasonable expenses.
I would just add, I would think about the two separately. So I think the expense concept is really more about a general responsibility to ensure, like Tiffany was saying, you didn't just decide in 2010 that this was a reasonable fee for a service and you never looked at it again, which is certainly not how we do things. But when you come to the actuarial assumptions, I think that's looked at from a different lens, and it's a good thing, I think, that the actuaries will give the board an option. That's a range of options that they have determined are reasonable, and all reasonable to meet that assumed rate of return so that we can meet the promised retirement benefits that that the members have been promised.
Thank you.
Anybody else? Okay, so I do have two public comments on it looks like Bagley-Keene. I have Margaret Brown and Michael Flairman. Margaret, you can go first. Your thing came in first.
Thank you. Good afternoon. Margaret Brown, Retired Public Employees Association. Ryan is here with me holding a chart based on every CalPERS posted investment committee agenda item from 2013 through 2025. Consent items were not utilized for this chart. We classified every remaining agenda item using the label CalPERS placed on the agenda, whether it was information or action. Included in this chart are both open session and closed session agenda items. And what you can see is that the results are striking. Good, he's showing it to the audience. Thank you. In 2013, the investment committee had 35 substantive action items. By 2025, it had made only 3. This data is not cherry-picked. The tenfold decline is visible year by year across the entire period. The decline is gradual, sustained, and unmistakable. This graph poses one overriding question: what happened? What happened to the investment committee's role in actually making investment decisions? The distinction between an information item and an action item is not semantic. An information item asks the board to listen. An action item asks the board to debate and decide. Listening is useful. Receiving presentations is useful. Asking questions is useful. But those things are not governing. A fiduciary board governs by making decisions, taking responsibility for those decisions, and creating a record showing who approved what. Over this period of steady investment committee decision decline, CalPERS did not become less complex. Its investment program included exposure to private equity, private debt, leverage, external managers, fees, conflicts, and illiquid assets. Instead, the investment program became larger and more complicated. So again, what happened? Where did these decisions go? Who makes them now? And how are board members and the public supposed to hold anyone accountable when the board itself so rarely votes? Staff may be exercising its delegated authority. Consultants may be making recommendations. The board may be receiving extensive information, but information is not authority. Performative oversight is not responsibility. This is not an accusation about any single investment or any single person. It is a structural governance problem documented over 13 years using CalPERS' own data. RPA is asking the board to publicly explain this decline. You should review your delegations and practices that produce these alarming results. Just one more moment, please. I would like you to restore the governance structure in which the elected and appointed fiduciaries do more than
Margaret,
watch
your time's up,
the
please.
investment program operate. Thank you.
Mr. Flerman?
Good afternoon. My name is Michael Flerman from RPEA. My comment concerns what the Bagley-Keene training materials do not discuss. As your counsel just noted, Government Code Section 11126C16 permits CalPERS to hold closed sessions when considering investment decisions. That's a specific exception to California's open meeting law. Yet, despite the vague acknowledgement that your counsel provides no guidance on what considering investment decisions means, or how board members should distinguish a permissible closed session from an impermissible investment strategy session. That omission is extraordinary because the scope of closed session authority is among the most controversial issues in open session meeting law everywhere, and because CalPERS invokes closed session authority over investment discussions constantly. For example, yesterday the board moved from an open presentation by 2 leaders of the Goldman Sachs Global Institute into a closed session titled Goldman Sachs AI Investment Strategy Session, citing this provision of law. Before the board entered the closed session, I asked a simple question: will the board closed session with Goldman Sachs be considering an investment decision? No investment decision had been identified on the agenda, and the item was in fact labeled as merely a strategy session. The presenters were from Goldman Sachs' internal think tank, not its investment management business. Their materials almost certainly contained the firm's standard disclaimer that it was not investment advice and could not be relied on in making investment decisions. No one answered. I was told only that the board does not respond to questions. This is not an isolated ambiguity. RPEA conducted a review of investment committee agendas since 2013, you can switch now, and found roughly 775 items justified as closed session. That's all of these greenish ones, under the considering investment decisions decision exception. Yet of these 775, approximately 750, I'm sorry, the 750 are the green, were separately labeled as information only, meaning not action items. The action items are down here. There were about 25. So you have 750 versus 25. You can readily see the problem. The agenda repeatedly labels almost all the board's closed session investment items as information only, yet the same agendas cite investment decision considerations as the statutory authority cited to exclude the public. That tension deserves an explanation. I would ask each of you to decide for a moment how not how things have traditionally been done, and ask yourselves a simple question. If this record were placed before a judge who knew nothing about CalPERS, what would
Your
the
time
judge,
is up, sir.
What would the judge?
Your time is up, sir.
What would the judge see?
We hear you.
Thank you.
All right, thank you very much. Oops. So that wraps our open session for today. Let's give the presenters a round of applause. Thank you very much for the training.
Thank you.
And with that, we will recess now into closed session for the Fraud Security Roadmap session. And pursuant to Government Code Section 11126, Subdivision C18A, the Board of Administration needs to approve meeting in closed session for the Fraud Security Roadmap agenda item. The Bagley-Keene Open Meeting Act requires at least 2/3 of the board members to present to vote approval in order to hold a closed session to consider matters posing a potential threat or criminal activity against CalPERS property or equipment, including electronic data, and where disclosure would compromise CalPERS security. Based on consultation with our legal office, discussion concerning the Fraud Security Roadmap qualifies for this closed session exemption. After the closed session, the committee will briefly report out in open session that we met under this exception, and if any action was taken. What's the pleasure of the committee?
Could we meet in closed session to discuss the matter?
It's been moved by Mr. Miller and seconded by Mr. Palkey. All those in favor say aye.
Aye.
All those opposed? Any abstentions?
I don't know what that is that we're voting on. I meant to ask, I didn't like think quick enough. The agenda item itself.
We are voting, oh, you don't know what we're voting on?
Right, how can I say, yeah, we should be here, or no, we shouldn't be here if I don't even know what here is?
Okay, so you abstain?
That's what I did.
Okay. I don't think I can say that in open session. What we're going to be talking about, it doesn't say we're voting on it, is the Fraud Security Roadmap.
Why don't I?
Okay, well, I can't talk about it in open session.
Why don't I chime in quickly? I'm sorry. So Bagley-Keene requires for this particular closed session item, which deals with potential, I'll put it this way, the potential threat to CalPERS information security systems, that kind of a thing. Unlike other closed sessions where we can just adjourn, it requires the board to take a 2/3 vote. So that's the reason why we have to go through this extra step that is different from all the other closed sessions. And the board basically has to vote to say, we agree, and you're agreeing based on the advice of your legal counsel that this closed session is appropriate. Sorry about that.
Okay, motion carries. And we will now recess into closed session. I need to clear the room.
don't know if it's been cleared.
reporting out on the fraud security roadmap. We are back in open session. The board received information on the fraud security roadmap. No action was taken, and this adjourns today's meetings. Day 3 of the offsite will begin at 8:30 a.m. tomorrow morning. Thank you, and I look forward to seeing everybody in the morning. Thank you. We are adjourning the meeting.